effective and implementable research that plays a role in supporting the resolution of public health problems. 3. Carrying out quality of community services in supporting development programs in the health sectors. Implementing governance with culture and integrity. 5. Developing collaboration that is able to increase the value of the institution in implementing three dharma of higher education and utilizing graduates. Mataram Health Polytechnic has values, namely berintegritas, culture, innovation, integration, grade, and aspiration. There are 12 study programs spread over 4 departments. There are Department of Medical Laboratory Technology with 2 study programs, Nutrition Department with 2 study programs, Nursing Department with 5 study programs, and Midwifery Department with 3 study programs. Currently, the Mataram Health Polytechnic has obtained 12 accreditation certificates at the diploma, Bachelor of Applied Science, and professional levels with an excellent A grade and excellent B grade. Mataram Health Polytechnic has 3 campus buildings, including Campus A and B in Lombok Island, Mataram City, and Campus C in Sumbawa Island, Bima City, with a total area 58,821 square meters. Mataram Health Polytechnic has competent human resources consisting of State Civil Service or ASN and non-state civil service staff. A brilliant achievements have been achieved for many institutions, lecturers, and students at the national and international level. Mataram Health Polytechnic carries out social activities and community movements based in a good cooperation with the industrial world, domestic university, and foreign universities. The implementation of research and community service refers to government programs, that is, research and community service programs, in order to support the 3 dharma of higher education. The supporting elements for facilities and infrastructures are quite adequate, such as an information and technology laboratory, competency laboratory, library, gazebo, meeting room, large parking area, buses, 4-wheel vehicles, and sport fields. To make the Mataram Ministry of Health Polytechnic a reference center for higher education, both national and international, a great design for medium-term and long-term business strategies until 2037 was prepared.
Before we starting, Bapak Direktur Politeknik Mataram, and all speakers. We would like to starting the event in a few minutes. Welcome to International Webinar of Health Polytechnic Ministry of Health Mataram 2024. Our respected Director of the Health Polytechnic Ministry of Health Mataram, the Honorable, our respected speakers, and the Honorable all the participants of today's International Webinar. Good afternoon, ladies and gentlemen. Praise be to God Almighty who has given us health and opportunity so that we can gather at Health Polytechnic Ministry of Health Mataram International Webinar with the theme Improving Early Detections, Treatment, and Care for Cancer in Hospital and Community on Thursday, 28 November 2024. I am Fadila Rizky Ananda, the host will read out the schedule of our program this afternoon as follows. First agenda is opening. Secondly, singing the Indonesian national anthem Indonesia Raya. Third agenda, opening speech by Director of Health Polytechnic Ministry of Health Mataram. Fourth agenda is the photo sessions. Fifth agenda is the presentations by the speakers. And lastly, closing. Let us start the agenda by saying Al-Basmalah, Bismillahirrahmanirrahim. Next sessions is the singing the national anthem Indonesia Raya. Ladies and gentlemen, as a mark of respect for the Republic of Indonesia, we will now listen to the national anthem and we invite all participants to join us in this moment of national pride. Thank you, ladies and gentlemen, for your participations in honoring the national anthem of the Republic of Indonesia. The next agenda is the opening speech as well as opening the event by the Honorable Director of Health Polytechnic Ministry of Health Mataram, to Dr. Yopi Harwinanda Ades Kurt. The time is yours.
Thank you. Is my voice clearly?
Yes, Pak.
Okay. Okay. I'm sorry, I am on my way from Jaika office. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good afternoon, the honorable speakers. The first speaker, Dr. Rian Pasita, PhD, from 11 Maret University. Hello, Dr. Rian.
Good afternoon.
I am graduated from there.
Oh, really?
11 Maret University. Yeah. Postgraduate, magister and doctoral also. And the second speaker, Miss Jenny, PhD from University of Philippines, Los Banos. And the last speaker from the other country, Dr. Siti Nur Khairina binti Sofali from the National Islamic University Malaysia. And the speaker, the honorable leaders of Mataram Health Polytechnic, Nusa Tenggara Barat, and the honorable and protocol of international participant of webinars and the committee. Syukur, Alhamdulillah, we express our gratitude to the presence of Allah Subhanahu wa Ta'ala from the help that had been given to us. It's a privilege to welcome you all to this international seminar on improving early detection, treatment, and management of cancer in hospital and communities across the country. Today, we share the same vision to improve our collective understanding and action in combating one of the most pressing health challenges of our time. It's cancer. The theme of this webinar underscored the urgent need to improve early detection and multidisciplinary care strategies in hospitals. Early diagnosis is critical because it can significantly improve to the success rate of treatment and overall prognosis for cancer patients. Through this event, we aim to deepen participants' insight to the latest advances in cancer diagnosis testing, treatment protocols, and the range of services available to patients in the healthcare setting. In addition, This meeting is an opportunity to strengthen collaborative research effort, not only within our border, but also across the national borders. We strive to foster strong partnerships with other institutions and agencies, facilitating non-research collaboration that can lead to more holistic and impactful solutions by developing products based on local cultures. We can introduce innovative and context-specific approaches that are relevant to communities research. In addition, establishing partnership and business contract with industries and organizations abroad is essential to harness global expertise, technology, and resources. Such collaboration will enable us to create a stronger and more resilient network that is able to effectively respond to the need of cancer patients and their families. I encourage all of you to actively engage in today's discussion, share your valuable perspective, and collaborate with fellow participants. Only through collaboration and knowledge exchange can we make a substantial impact in the early detection, treatment, and holistic care of cancer patients. Let us remember that the progress we make today will lead the way for healthy communities and a future where cancer is faced with greater hope and better outcomes. I'm confident that with the commitment and expertise brought together here, we can create a stronger, more effective, and more compassionate system of care. Thank you for your vision and participation. Let us make the most of this opportunity and move forward together. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Yopi Harwin, the art director, for the inspiring opening speech. Then the next sessions. Before entering the main event, we would like to have a group photo sessions. So participants who are in the Zooms are expected to activate their cameras because we will have a group photo sessions right now. For the participant, please turn on the cameras. We're starting from the first slide. In 3, 2, 1. Next 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 slide. In 3, 2, 1. And next slide. Prepare yourself. In 3, 2, 1. Slide again. In 3, 2, 1. Slide. In 3, 2, 1. Next slide. Prepare yourself. In 3, 2, 1. Slide. Three, two, one. Thank you, everyone. That was the opening ceremony of the Health Polytechnic Ministry of Health Mataram International Webinar 2024. Now, let us proceed to the main sessions of our webinar, which will be handled by Mr. Ari Kusuma and Ms. Nursanya Fahmi Mantika. Mr. Ari Kusuma is a lecturer in the Department of Medical Laboratory Technology with specializations in situ histotechnology, molecular biology, and has contributed significantly to advancing education and research. So, the next sessions, we will witness the presentations of speakers, and we are honored to have Mr. Ari Kusuma guide us through these sessions.
Okay, thank you so much, MC. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Yes, good afternoon to all of you joining us from various part of Indonesia, audience from Malaysia and Philippines. And I would say welcome to the international webinar of Health Polytechnic Ministry of Health Mataram 2024. It is an absolute honor to have such a distinct and global audience with us today. Our theme this year is improving early detection, treatment, and care for cancer in hospital and community. Over the next few hours, we will explore critical insight into cancer diagnosis, treatment, and care shared by experts in the field. Before we proceed, my name is Ari Kusuma, SSCM Biomed, and I will be your moderator for today in first session webinar. Together, we will delve into key aspects of cancer management, from diagnostic to treatment and prevention. I encourage everyone to stay engaged throughout our session and participate actively during the Q&A. Let's ensure that we have a smooth session by kindly keep your microphone mute during the presentation, and feel free to type your question in Q&A box, and we will address them at the end of each speaker sessions. Today, we are privileged to have three speakers in the first session who will share their expertise of cancer management. Each speaker will have 30 and 45 minutes for their sessions, followed by Q&A segments. Our first speaker is Dr. Brian Wasita, PhD. Hello, Doctor.
Hello, Assalamualaikum, Miss Ari Kusuma.
Waalaikumsalam. How are you, Doc?
I'm fine, thank you. How are you?
I'm good. We meet again, Doc, in our
Yes,
second meeting in the Zoom.
Yes.
Yes. Yeah, for today, Dr. Brian will present on laboratory tests used for cancer diagnosis. This session will highlight the key tools and techniques that are shaping how we detect cancer in the early stages. Without further ado, please join me in welcoming Dr. Brian Wasita. The virtual stage is yours.
Thank you very much, Miss Ari Kusuma, Mr. Ari Kusuma, SSCMSI. Assalamualaikum warahmatullahi wabarakatuh. The Honorable, the Director of Poltekkes Mataram, Dr. Yopi Herwinanda Adesa MKes, the Honorable all of the speaker, committee and participant, thank you very much for inviting me for sharing about the anatomical pathology examination for diagnosis of the cancer. This honor for me to share our work every day, our everyday work to you, how we in the anatomical pathology department diagnosis the cancer using our examination. I would like to share my PPT. Thank you very much. So for this session, I would like to sharing about anatomical pathological diagnosis of cancer. So I came from the Department of Anatomical Pathology, Medical Faculty, Universitas 11 Maret, General Hospital, Muardi General Hospital. And this is our work, our everyday work to diagnose the cancer. So we have several examinations to diagnose the cancer. So for the highlight of the topic today, I would like to show you the topic outline. The first is the rule of anatomical pathology examination. And the second one is this anatomical pathology examination. In this session, I would like to introduce to you and sharing to you the examination that we held every day, histology, histopathology, and molecular pathology to diagnose the cancer. So the first one is the role of anatomical pathology examination in the diagnosis of cancer. So anatomical pathology diagnosis is very important in the oncology fields because, as we know, the anatomical pathology diagnosis is still the gold standard. However, in the everyday life, everyday's working, we recognize about triple diagnosis. So the triple diagnosis is very important because we need to cooperate with other colleagues to give the best diagnosis for the patient because the best treatment is come from best diagnosis. So first is clinical diagnosis when the patient came to oncology surgeon, for example, if the patient has the lump in the breast and the oncology surgeon will examine the patient, have the anamnesis, physical examination, and if there is suspicious mass the breast, for example, the oncology surgeon will send the patient for consultation in the radiology department, and usually there will be an examination, for example, mammography or USG ultrasonography, and from the examination there will be a result. For example, this is suspicious for malignancy, for example, BIRAT, usually use BIRAT 4 or 5 or 6, and then usually the doctor, the oncology surgeon will send the patient for consultation to our department in anatomical pathology, and we will perform fine needle aspersion biopsy to confirm what is the lesion. This is the tumor or not, or this is benign or malignant tumor. For example, in this case, this is malignant tumor, so the result of the AB and also radiology examination will concluded by the oncology surgeon, and the oncology surgeon will give the treatment for the patient depend on the result of the our examination. And in this case, this is the malignant, so the oncology surgeon will perform mastectomy, and the tissue, the breast tissue, will send again to our department to perform final diagnosis. This is a microscopic and microscopic examination. And if we have a difficulty, for example, not all the cases is easy, and not all is look like a textbook because because we are in the type A hospital, referral hospital. So the case that came to us is usually the difficult case. So in the case of the difficult case, we usually have a discussion between oncologist, radiologists, and pathologists, and we speak together, discuss together what is the best diagnosis for the patient. So until now, the pathological diagnosis is still the gold standard for diagnosis because we diagnose from the specimen or from the tissue become cancer. So for the rule of anatomical diagnosis is very important to make the treatment decision, because if our diagnosis is benign, it's different from the treatment if compared if our diagnosis is malignant. So there is a different. So this is important for treatment decision. And also the anatomical pathology diagnosis is important for prognosis evaluation. For example, we also performing molecular examination, for example, immunohistochemistry for ER/PR, HER2, and Ka67 to evaluate the prognosis breast cancer. So another diagnosis is very important for treatment decision and prognosis evaluation. And for accurate diagnosis, I always mention that the fixation is very important. The fixation is we put the specimen on the tissue from the operation, after operation, directly to the fixation liquid. For example, neutral buffer formalin 10%. This is very important because the fixation will maintain the structural composition of the tissue and also maintain the DNA, RNA, and protein. So it's important for our examination. And the second one is triple diagnosis. The clinical and radiological data is very important. So it's very important, the fixation, because the fixation will maintain the integrity of the structure. And if without fixation, the tissue will decay and also will make a necrosis, and there will no diagnosis. And without good fixation, we cannot also perform a higher and a more advanced examination. For example, molecular examination in the immunohistochemistry or mutation analysis. So without no fixation is endgame for the specimen because we cannot do anything again. So the fixation is very important. And for the fixation agent, for the tissue, it is commonly we use neutral buffer 10%. And for cytology, for example, pap smear and FNAD, we use ethanol 95%, and from the liquid, free infusion acetate and all other and etc. We use the ethanol 50% with ratio by one by one. These figures show what how is the importance of a fixation. This is a immunohistochemistry staining. This in the left side is estrogen receptor staining, and the right side is progesterone receptor staining. And with the time, this is directly less than 30 minutes, and this is 4 hours, 8 hours, and overnight. So we can see that the expression of the estrogen receptor and progesterone is decreasing with the delay of the fixation. And this is if, for example, the cutoff of the ER examination is 1%. So if it's only 5% here, so if we delay the examination, so maybe in the overnight there will be no expression of the ER. But this examination is very important to decide if the patient can get the treatment. So this is it's very important for us, all of us, to maintain the integrity of the structure, DNA, and protein using good fixation. And the second part, I would like to sharing about anatomical pathology examination that we usually use every day for diagnosis of the cancer. So the first examination is cytology. Cytology, we perform examination on the cell. So there is several examination in the cytology. This consists of pap smear, fine needle aspirate biopsy, perfusion, urine, sputum, acid test, and etc. And then histopathology examination. This is the core examination of the anatomical pathology diagnosis. In the histopathological examination, we perform examination of the tissue, the affected tissue. And then not something in our hospital is a lot of difficult case. So we cannot only performing histopathology examination because the tumor is for diagnosis the tumor is not very easy. So this is difficult. For example, the tumor with the same morphology and for example, we need to decide if this is metastasis or primary tumor. So we performing molecular pathology diagnosis also. There is several examination, immunohistochemistry, fish fluorescent in situ hybridization, or cheese chromogenic in situ hybridization, and we also perform mutation analysis for EGFR and also liquid biopsy if necessary. For the cytology examination, there is several examination. This is, for example, fine needle aspiration biopsy, pap smear. The pap smear usually fine needle aspiration. This examination is performed by our department and also other doctor, but our department also perform fine needle aspiration biopsy. Pap smear usually is performing by obstetric and gynecology doctor. Sputum, bronchial ablation, bronchial washing, TPN is performing by pulmonologist, urine acid test, and etc. Usually we receive the sample from other department. For fine needle aspiration biopsy, actually this is the operative diagnosis. As I mentioned earlier, that if the doctor find a lump or a mass in the breast, for example, the doctor need to confirm that this is a tumor or not, or this is if tumor, this is benign or malignant. So the fine needle aspiration biopsy is the choice, the one of the choice for determining the preoperative diagnosis. Besides fine needle aspiration biopsy, there is also another explanation, for example, cord biopsy. But this is a more easy, easier to perform, and is inexpensive. So this fine needle aspiration biopsy also can be performing in the superficial and also in the deep lesion. So not only the mass or the lump in the superficial lesion, but also in the deep lesion, for example, in the liver, spleen, kidney, spine, we can perform the FNAB. So this is minimally invasive because we using small needle, fine needle, and also relatively speedy result. We can get the result in for at least 2 hours. We can get the result, and it is inexpensive. But it also have limitation. For example, it depend on the operator or depend on the doctor that perform the FNAB. And if we need to perform another examination, so we need to make a lot of samples. So sometimes we cannot get a lot of sample. So this is one of the limitation. And also there is some cancer that we cannot diagnose with the FNAB. For example, thyroid, yes, thyroid cancer. Some of the thyroid cancer, we need to examine the border, the capsule of the cancer. So we cannot perform using FNAB. But however, in some of the lesion, we can decide it whether this is benign or malignant. This is the equipment of the FNAB. This is a slide. This is chemical. This is to withdraw the liquid from the lesion. This split, and this is the needle. Usually use needle from 25 until 28 each, and also this is liquid fixation liquid. So it depends on the staining that we will use. It have different liquid. This is the procedure of the FNAB. This is for the tissue, for the lesion, or for the mass that are difficult to palpate, or for example, or have deep structure, and also have heterogeneous component. We need to perform on the fine needle aspiration biopsy with guided ultrasonography or guided CT scan. So we will if we use the guided FNAB, we can directly guide the needle to the lesion that we need. And this is without guided. This is thyroid. Usually we performing the FNAB without guided if the lesion is homogeneous. So if the heterogeneous, we need to use FNAB. And also can perform the FNAB without the chemical, with only using needle. If we need to perform another examination, for example, molecular examination, we can make the cell block from the result of our FNAB. And for this fixation and staining, there is various staining and fixation. So we depend on the laboratory, depend on the staining of the laboratory. We can use Papanicular staining, Kim-Sa staining, or hematoxylin Osin staining. For rating system, actually there is several systems that are already established. For example, in the breast cancer, we usually use FNAC system from C1 until C5 malignant, and for thyroid lesion, we usually use Bethesda system for reporting system. This the figure that show benign lesion. On the left side, we can show the cell that have a cohesive cell. This in cluster of the cell. The cell is still in our terminology is monomorph. Yeah. Monomorph is same size, relatively the same cells. Cytoplasma is still a mon, and the nuclear is fine nuclear. chromatin nuclear. So and also we can find some macrophages here. This is a fibrocystic change. And the right side, we also has the same, almost the same, cohesive cluster of the cell, but we can also find a lot of myoepithelial cells. So this is fibroadenoma. This is malignant lesion. It is very different with the previous one. We can see in the cell is pleomorphy with various size and various morphology, and the cytoplasma is a small amount, and we can find coarse chromatin with prominent nucleoli. This is the invasive carcinoma of the breast, and this is specific. This is an Indian file feature. So this is an invasive lobular carcinoma, and this is also we can find some mucinous mucinous area. This is mucinous adenocarcinoma. So from the actually in the FNIB, we just need to describe about from the C1 or C5. But if we can found this is in the specific manner, we can suggesting diagnosis that probably if this is invasive carcinoma of the breast. And then the pap smear. In the pap smear, we have conventional smear and liquid-based cytology. And this is pap smear. I think all of you already familiar with the pap smear. This is a conventional pap smear, and this is using brush. And this is the tool for the pap smear. Nowadays, we use the brush. And after this, we can take the specimen from the seal of the cervix, and usually the brush will be placed into the. This is a fixative solution. So for the fixative solution, they will be processed into the slide for cytology examination, and the rest is used for molecular examination, for example, for HPV, genotyping of HPV. For reporting, we use a beta star system, and this is a sample of the result of the pap smear. And this is a we can see in the squamous cell carcinoma, cell is very various pleomorphy with very clear nucleoli and coarse chromatin. This is the next examination is sputum. In the sputum, we usually we usually try to find the tissue fragment, blood, or element, and then we smear and then fix in 95% of ethanol. We can also performing make the cell block for the if we need to perform a molecular examination. The sensitivity and specificity are relatively high, for example, especially if we take more than 5 specimens. And this is the figure show sample of the sputum examination. This is sputum with this is a malignant cell with keratinization, and tadpole cell. This is a square carcinoma, and this is adenocarcinoma with a cell in cluster and vacuole cytoplasm and nucleoli. And also this is look like the tubular formation. So this is adenocarcinoma. And then the next examination is bronchial specimen. Usually we receive this specimen from the pulmonologist. There is various examination that we can perform. This is a bronchial washing, bronchial pressing, and effusion pleural examination. And we for bronchial pressing, and the pulmonologist usually already smear into the slide, and then we mix the fixation with ethanol, 95% ethanol. And then for bronchial washing, usually this pulmonologist send us the liquid that from the bronchial pressing, and then we performing fixation and also processing the bronchial washing into the slide. And this is the example of the bronchial pressing. So we can see here that the cluster of the cell with clearly nucleoli and vacuolated cytoplasm. This is a adenocarcinoma, and this is from washing. We can find this is very specific tadpole cell with keratinization, And this is also from washing. This is adenocarcinoma. You can see that there looks like the tubular formation here and then the clear nucleoli. And then TBNA, pulmonologists also can perform financial aspiration biopsy using bronchoscopy if they find any suspicious mass in the bronchus. And this is TTNA, transthoracal. So it looks like FNAB, but in the lung tissue. So with the CT guided or OSG guided, the pulmonologist take the sample and send to us. And this is the algorithm of the specimen that we take that we receive from the pulmonologist for TTNA or pleural effusion, bronchial cross-brushing or pressing, and because in the lung so there is a lot of examination that require to determine the treatment. So we need to think about the sufficiency of the sample because the specimen should be examined for AGFR mutation analysis, ALK, and PGL1 because all of these examination will decided whether the patient can have the treatment for anti-GFR, anti-ALK, and anti-PGL. For the urine, we usually take urine from 3 to 4 hours from the patient last urinated and midstream around 25 to 100 milliliter of the urine. And this is this example of this examination of the urine. This is high-grade urothelial carcinoma. And the next one is histopathological examination. So this is the core examination of chemical pathology examination. In the same as cytology, we need to fix this tissue. It is very important to fix the tissue. We usually fix with neutral buffer formalin 10%. So, and the fixation time is very important, 8 to 72 hours. It's important to fix minimal is 8 hours. So after the specimen is received in our department or laboratory, we usually keep the tissue in the fixation liquid for at least 8 hours, usually around 8 to 12 hours. And the maximum is 22 hours. Why is 72? Because after 72 hours, it is very difficult for us to make a good immunohistochemistry examination because of the crosslinks of the patient to the fixation, to the tissue. This is macroscopic examination, ladies and gentlemen. So we cut the tissue and we measure. We find the tumor and we measure in 3-dimensional size. And then we also examine whether there is a margin, how is the margin, which is a clear margin or active margin, and the consistency of the tissue, which is soft or hard, or we need to describe. And also we need to describe whether there is a necrosis or area of bleeding. So we describe the lesion. This is very important because the pathologist will select which part of the tissue that we need to take for microscopic examination. For microscopic examination, we usually using the WHO classification diagnosis. So this will be the same. Our result will be the same as other pathologists in the world. So for epithelial lesion, for example, invasive breast carcinoma, there is a various type of breast carcinoma microscopic, and this type is have a different prognosis and different response to the treatment. So we need to precisely diagnose the breast cancer. We use modified carbon reduction histology grade to decide the histology grade of the breast cancer sample. The higher grade is the more malignant of the cell. This is the example of the breast cancer invasive carcinoma from grade 1, grade 2, and grade 3. And this is various type of invasive carcinoma. For example, this is lobular carcinoma, mucinous carcinoma, medullary carcinoma, and we need to diagnosis precisely about the structure of this carcinoma because it so different prognosis and different treatment on the response treatment. The next one is frozen section. This is very challenging for us pathologists because this examination is performing during the operation. So the patient is still in the own operating room, and the doctor will take some part or sometimes a whole part of, for example, ovary. The doctor will send us the ovary and would like to know whether this ovary is malignant or benign. So it is very challenging because during usually in our hospital we only have around 40 minutes to decide it whether this is benign or malignant. So this is challenging examination because the result of examination will decide it will give the doctor to make the decision whether the operation is stopped or the operation is continue with some action or will all take the radical operation. So this is very important for the patient. This is the machine that we use for in Muardi Hospital, and this is the sample when the if for example this is the ovary came to our department, and then we check, we cut the tissue, and we select this is the tissues for the lesion, and then we take the tissue, and this is with OCT compound. We freeze the tissue, and then we cut, and then we performing staining, and then we make the diagnosis whether this is benign or malignant. So if we benign, so doctor will, for example, for the breast scans, for the breast tissue, breast mass, if the result is benign, so the doctor only performing lumpectomy. But if the result of the sensation is malignant, so the doctor will make the more aggressive treatment, for example, mastectomy or radical mastectomy. So this is important, and this is performing in limited time because the patient is still in the operating room performing and still performing surgery. And the last one is molecular pathology examination. We one of the examination that we routinely performing for molecular examination is immunocytochemistry or immunohistochemistry. This is the examination to detect the protein in the tissue or in the cell. So we performing activity especially for aiding the diagnosis of the cancer. This is the method, SIB and polymer. Over this, we use a polymer method, and we use machine. So the ICSA, improved current signal amplification, is the best one. Fixation is almost say 8 to 70 hours. This is the step from the slide processing, then deparaffinication, antigen retrieval, quenching, blocking, antibody incubation, primary antibody incubation, washing, detection, washing, and then we after retreating and mounting, we performing microscopic examination. There's actually this long step for performing immunohistochemistry, so we need to carefully in every step so that the result will be standard. So this is the layout of the laboratory for doing immunohistochemistry. For application of immunohistochemistry, we usually perform chemistry for diagnosis of the tumor. For example, we get the tumor with higher grade tumor, so we do not know whether it's carcinoma, lymphoma, or melanoma maligna. So we performing immunohistochemistry, for example, cytokeratin, CD45, 19, and so we can decide whether this tumor is carcinoma or lymphoma or sarcoma, because the treatment is very different. So we need to precisely diagnosis. Or we need to we have example of this one. Diagnosis of carcinoma of unknown primary. Sometimes there is a metastasis foci that we don't know whether which width is the original of the metastasis tumor. So we can performing immunohistochemistry, for example, CK7, CK20, CTX, lung, TTF1, and other ones. So we can then we can decide whether the tumor is primary tumor or secondary tumor and other things. This is the machine that we use for performing immunohistochemical staining. I recommended that we use the machine because the result is better than if we performing immunohistochemistry manually. And this is the sample of the immunocytochemistry and immunohistochemistry. This is if we performing FNAB and then if we found that there is a cell that suspicious for Hodgkin lymphoma, for example. So this cell can be stained with CD30. This is a marker for Hodgkin cell. So if this is positive, so this case is high likely it is a Hodgkin lymphoma. And this is for example, this is we found the cell. This is look like a carcinoma. We don't know whether this is primary or secondary. So we can stain with. This is a TTF1. This is a marker for adenocarcinoma of the lung and thyroid. So this is the positive, highly positive, and this is adenocarcinoma of the lung. And for example, this is spindle cell. This is actually this is a difficult case. We need to perform several staining, but in this case, this synaptophysin staining is positive, so this is a neuroendocrine tumor. And this is from the lung tissue, from the from the liver. If this is from the liver, that from the liver, and liver is the favorite place for metastasis. So this is difficult for us. If we have the nodule of the liver, we need to confirm whether this is a primary of the liver or metastasis. In this case, the PCA staining is positive and HEPAR1. HEPAR1 is the staining that relatively specific for liver. So if this is positive, so it means that this is a tumor from the primary of the liver, hepatocellular carcinoma. And this is, for example, this is a spindle cell. This is malignant from the morphology. And this is a lot of, so if we suspect this is a tumor, a malignant tumor from the blood vessel, so it can be stained with CD34. And this is positive, it is angiosarcoma. And this is performing by our hospital every day. Breast cancer, usually the oncologist will ask to performing the staining AR, PR, HER2, and Ke7 to determine the molecular subtype of the breast cancer and to determine whether the patient can have the treatment or not. This is ER, PR, HER2, Ke67. This is all of the positive. And from the result, we can divide it, the tumor into molecular subtype. This is the molecular subtype will have a different response of the treatment and also different prognosis. We have illustration, a 50-year-old woman with mass in the pancreas. And this is the pancreas mass, but the patient has history of breast carcinoma. So this is, we found something strange here. This tumor is not belong to the pancreas. So we suspected that this is the metastasis from the breast carcinoma. So we performing mammoglobin immunohistochemistry and it's so positive. So this is metastasis lobar carcinoma of the breast. We diagnosed this case with metastasis lobar carcinoma because mammoglobin is specific for breast tissue. And this one, for example, we have cellular uniform morphology cell. This is very difficult to pathologists diagnosis without immunohistochemistry because there is a lot of chance that this is a non-Hodgkin lymphoma or Ewing sarcoma or Rabangodu sarcoma. So we can perform CD99 staining. So if we get the result strong, diffusely positive, this is Ewing sarcoma. This is ependymoma from the brain. We have perivascular pseudoresept And we need to check whether this is really ependema or not. So we can perform a GFAP, glial fibrillary protein staining. So if this is positive, and also EMA staining, if it is positive, so this is ependema. This is also from the brain. There is a tumor cell, a perivascular tumor cell with monotonous figure. So we suspect if we suspect that this is lymphoma, so we can perform CD20 staining if this is positive. So this is non-Hodgkin lymphoma, P type. And also this is if the tumor cell with nested pattern and Zell-Ballen pattern, the relatively with flat pleomorphy and fine clean. So if we suspect that this is a neuroendocrine tumor, we can perform staining, for example, synaptophysin staining, chromatogranin A staining, Ka7 for grading the tumor. And this is all positive, so this is neuroendocrine tumor. Because of the Ka7 is more than 20, so this is neuroendocrine tumor grade 3. So this is how we can see how important is immunohistochemistry staining for the diagnosis. And the next examination in situ hybridization is not relatively routinely performed because we usually use this one only for checking the staining of HER2. But actually, this has a lot of very edges for the diagnosis of the tumor. So for in situ hybridization, we usually use the kit from the company that already has the examination, the target probe, DNA probe, and labeled with fluorescent, and the DNA will denaturate, and then we perform hybridization and detect with microscope, fluorescent microscope. It's the same hybridization, and then detect with microscope. The step is differentiation. This is FISH protocol. It's already stated in the kit. Hybridization was contested and we examined with fluorescent microscope. This is the protocol. This is some study that already established regarding the diagnosis of solid tumor using FISH. For example, breast cancer, there is amplification of HER2. This is amplification of HER2, and this is the target drug for molecular target therapy, for example, trastuzumab. So we usually performing immunohistochemistry for determining whether the patient can the HER2 anti-HER2 or the trastuzumab. If this patient have positive 3, so the patient can get the trastuzumab. However, if the patient has positive 2, we need to performing FISH staining to confirm whether there is amplification of HER2 gene or not. This is the example. This is how there's no amplification of HER2, and this is there are a lot of HER2. So the pink one is the HER2, so this amplification of HER2, and it is also concordant with the immunohistochemistry staining. This is negative and this is positive, or positive 3. It is also almost the same. And nowadays, there was a technique called CHIS, chromogenic in situ hybridization. So if we do not have fluorescent microscope, we can also still performing in situ hybridization using chromogenic in situ hybridization. But the protocol is the same. So we can also get examination using ordinary microscope without the fluorescent microscope. And this one is PDA1 test. So this actually, this test is for determining whether patient can have immunotherapy using anti-PD-L1 or anti-PD-1. This is the basic of the test. This examination is in normal condition, the normal cell will express PD-L1 or ligand 1, and cytotoxicity cell will we have PD-1 receptor. So if there is a bonding between PD-L1 and PD-1, so the cytotoxic cell will be inactive and it will be inactive and not killing the normal cell. However, the tumor cell is very clever. So the tumor cell also express PD-L1. So there is a bonding between PD-1 and PD-L1 that was expressed by the tumor. So the cytotoxic cell will also consider that this tumor cell is the normal cell. So the cytotoxic cell will not kill the tumor cell. So the immunotherapy is breaking the bonding between the PD-1 and PD-L1 expressed by the tumor. So the cytotoxic cell will be activated again and will be reactivated and can kill the tumor cell. So the diagnosis flow of the PDL test is almost the same with immunohistochemistry because the PDL1 test is actually immunohistochemistry staining. However, there is a requirement that a minimum of 100 viable tumor cell. So before performing PD1 test, we need to count the cell, whether the cell is more than 100 or not. So this is the same using immunohistochemistry. For interpretation, for example, this in the breast cancer, we performing counting with CPS, combined positive score. We can get the score, whether this is the cutoff is 10. This is less than 10 or more than 10. So if the patient has a score greater or equal than 10, the patient can get the pembrolizumab. If less than 10, so the patient cannot get the pembrolizumab. So this is a molecular immunotherapy, precise treatment or immunotherapy. It is the same. CPS less than 10, CPS more than 10, and this is performing in our hospital is CPS less than 10. So the last one is a mutation analysis. We usually performing this analysis for lung cancer, GFR mutation for lung cancer. The sample can obtain the sample from tissue, paraffin block, cytology sample, and several. Because in Indonesia, the sample from the pulmonologist usually in the cytology. So we usually use cytology sample. For example, effusion pleura tissue sample, bronchial washing, TTNA, and we usually, if we had a lot of sample, we make the cell block so we can get a lot of sample for a lot of examination of HF, a lot of molecular examination. Usually we use real-time PCR examination with kit. Well, we need to examine EGFR because EGFR is important molecular pathway for lung cancer. And there is a different response of the treatment between the patient with a different set of mutation. For example, if we find the mutation in the exon 20, so the patient will be non-respond or resistant. So patient cannot be given with gefitinib or erlotinib. So this is very important examination because the drug is very expensive. So we need to make sure that if the patient given this drug, so it will be have the response. So if the patient mutation exon 20, so the patient will not be given, the doctor will not give the gefitinib and erlotinib to the patient. This is how we perform EGFR examination in our laboratory. This is the sample that we see from effusion pleura or other things, cytology examination, TTNA, bronchial washing. So first, the pathologist will examine this slide, and we need to circle. This is the area that contain the tumor cell. So we need to counting whether we can get the 100 cell or not. After that, then the area will be scraped and collected, and also then be performing extraction of the RNA, and then using kit we performing PCR, real-time PCR. Yes, and then from the curve. So from the real PCR, we can calculate using the formula whether this patient has mutation in exon 18, 19, 20, or 21. Thank you very much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Brian, for the insightful presentation. It's remarkable how advancement in laboratory testing is saving life by improving detection. And let's move to our Q&A session because we have a ton of questions in the chat box. Let's take a few moments to address questions from the audience. Doctor, so I have an experience doing some internship in hospital, and I do some of frozen section. I think it's quite hard to do.
Yes,
And
maybe,
yeah, maybe it's related to the question from Miss NPDA about, especially for the frozen section. What the best way to make sure that tissue sample is good enough for testing? I mean, we do some of frozen section. How we can know that the tissue sample is good?
So yes, thank you very much for your good comment. This is regarding tissue frozen section, Mr. Adi.
Yes,
For frozen section, we usually take the sample from the tissue and then we put into the cassette and then the OCT compound. And usually, to make sure that the tissue is good, so we cut the sample and we can see in the eyes. We can see there is a mark of the tissue, and we need to make sure that the tissue is not scrolling. So it's not going make a rebound, and then we can take the tissue and then stain, because the staining is very quick, because we have quick staining. So after we get the tissue will examined by pathologist. So if this is adequate, so we can make diagnosis. But if not adequate, we as a pathologist will ask another section for the tissue. But if the case is difficult and we need to, it's not clear yet, so we need sometimes we need to go back to the tissue and make another cut. So because it is very important, if we get the correct side of the tissue, we also need to check the clinical and radiological data of the patient, if this is suspicious for malignancy or not. So if it's very suspicious, for example, we will look around about the tissue, find again there is another side of suspicion. But if we already sure about all of the tissue that we already take, so as I mentioned before, we need to check whether the cut is properly cut. For example, there's no scrolling and all of the tissue is already covering within the cut. And because if it's a rapid examination, then we can repeat again if we not satisfied with the result.
Yeah, thank you, doctor. It's quite challenging when we do at the operation room. Yeah. Okay,
Yes,
thank you, doctor. Yeah, let's move to another question. I think it's Dr. Ahmad Fatoni. Maybe we can ask directly to Dr. Ahmad Fatoni. Hello, Dr. Ahmad Fatoni. Are you with us? Okay, Dr. Ahmad Fatoni. Dr. Ahmad Fatoni asking about why checking about prepared cancer sample takes really long time, doctor. And if you have an explanation about the different about
yes.
tumor and malignant and benign.
So this is very important to understand that the pathology examination is different with blood testing, for example. blood testing, we can take the blood and we can wait for 2 hours and then it will come the result. But for the histopathological examination, we need to make sure that the tissue already fixed with the fixative agent. So we cannot just make the slide microscopic without good fixation, because the good fixation make the we can get the clear result of the microscopic examination. So we need to wait until 8 hours, minimum 8 hours and maximal 72 hours. So it is already the time is already calculated with so the best time is for 8 until 72 hours, but not 72 hours. Usually if we receive the specimen today, so we will fix around 8 hours and then we process within 2 days. Usually if the specimen is not so big, not the bone, within 2 days we can get the result. So if it's not long time wait for period, because it's already standardized internationally that histopathological examination is the turnaround time is around 4 to 5 days, because we need time to make that the tissue is well fixed and well processing. So because it is different with the blood. The blood, we can take the blood and put into the machine and we can result. And different between benign and malignant. So I already mentioned in my presentation that the benign cell usually monomorph. Monomorph means the size is not variative size, and then the ratio between nucleus and cytoplasma is around 1 to 4, and the nucleus or the nucleus of the cell, we can see that the nucleus is have a fine chromatin, not coarse chromatin, and the nuclei usually not prominent. But in the malignant cell, we saw, as I previously mentioned in the slide, or I can show you maybe it is easier if I. Yeah, this one. Oh, I'm sorry. Yeah, this one is small benign cell. So we found that the cell is not pleomorphy, it's still the same size, the same feature, and the nucleus is fine chromatin, and this is the malignant cell. So we can find that there is a various size. There is small size, there is very big size, this is big size, and various morphology. This is a pleomorphy. In the pathology, we call this is a morphy. And the cytoplasm is in small amount. This is the ratio between nuclei and cytoplasm is the nuclei is higher than the cytoplasm. Normal cells, the nuclei is smaller. With the ratio is 1 to 4, and there is a coarse chromatin, the chromatin. So this is coarse chromatin, and there is a prominent nucleoli. This is, and also we can find mitosis. If we in the malignant cell, we find a lot of mitosis. So this is the difference between malignant cell and benign cell. So I will stop.
Okay, so we have quite different stage, yeah, Dok, yeah, between pathological clinical and pathological anatomical, because some of the people thinking that quite same with the pathology clinical. But
Yes,
actually,
because it's
yeah,
different.
we need to understand that this sample need to be examined really thoughtfully. So Thank you so much, Doctor, for
Yeah.
the explanation. Really helpful for us to understand about
Yes.
about pathology anatomical. We still have about 3 questions,
Yes.
but we run off the time. But no problem for
Oh,
all
yes.
the question. For all the question will be note and will be asked to Dr. Brian directly after this. But thank you so much, Doctor, for your time. You're addressing the
Thank
question
you very
so
much,
thoughtfully.
Mr. Ari Kusuma. Yes.
Yes, before we ending our session, would you like to give your closing statement, Doctor? Because most of us is a student of Technology Laboratory Medis. So you can give your closing
Yes.
statement.
Just thank you very much, Mr. Ari Suma, for the time. I think pathology is very interesting field. So because usually the technician not directly to the pathology anatomy. So anatomy pathologist is a very interesting field, and we have we have important role for the diagnosis of the patient, especially for the cancer. So I think it is important to student. We learn a lot of things, especially for anatomical pathologies. So it is important that the anatomic pathologist pathologist is included in the curriculum of the FTLM. I think it is important so that we can introduce to the student early as possible about the anatomical pathologist technique. So I think it is very interesting field, and this is also very important to study. So I hope that a lot of the ATLM will join the anatomical pathology fields. Thank you, Mr. Ari Kusuma.
Yeah, thank you, Doctor. We hope, Doc, our student able to understand more about pathology anatomy and maybe joining you at the pathology anatomy at University of 11 Maret, Doc.
Yes, please,
Yeah.
come to you.
Okay, thank you so much for your time, Doctor. I hope we can meet in the future event, Doctor. This is the end of our session. Thank you so much, and see you at the next event.
Thank you very much, Mr. Ari
Yes. See you,
Kusuma, and all
Doctor.
of you again. Thank you.
Thank
See you,
you.
Mr. Ari Kusuma.
See you,
Thank
Doctor.
you.
Okay, everyone. Thank you so much for your paying attention at the first speaker, Dr. Brian. And moving on to our second section, we'd like to welcome Dr. Siti Nurhairini binti Sotali from International Islamic University of Malaysia. Hello, Dr. Siti. How are you?
Hello, Dr. Ariko Soma. Thank you very much for the welcoming remark. Actually, my name is Siti Nurhairina.
Oh, Nurhairina. Okay,
Yes.
thank you so much for your time, Doctor. So today, Dr. Siti will discuss about treatment and care for patients with the cancer. This session will provide an in-depth look at the latest advancement in cancer therapies and how we can ensure compassionate care throughout the treatment journey. Let's give a warm welcome to Dr. Siti. Dr. Siti, the virtual stage is yours.
Okay, thank you very much once again. First of all, I would say that I would like to express my gratitude and thank you, particularly to the director of Poltekkes Mataram and the collaborator, I believe, over here, UPK SDM Kesehatan Mataram. And welcome everyone, students over here. I was being informed that you guys are mixture of nursing and non-nursing students. So for those from non-nursing students, just enjoy my lecture. At least you can get some insight because in the future, we are going to work in a team, in a multidisciplinary team. So at least during this webinar session, those from non-nursing students, you can learn something and get some insight what is actually the work of a nurse. So this, I was given the topic treatment and care for patients with cancer. Can you see my slide now, everyone?
Yes,
Okay,
Dr.
maybe
Siti.
to see it. All right. Okay. I hope please don't fall asleep. We are at 2:30. You already have your lunch, I suppose. So our eyes commonly will start to feel heavy after lunch. So I hope you all can stay focused. All right. I try to make some interactive session juga, if possible. Okay. All right. So did you see the picture up there, everyone? Just turn on your camera, say yes, or raise up your hand if you can see the picture. Okay. All right, good. That's response. Okay, anyone would like to try to answer my questions? What is the cells inside there? Can give a guess?
Jawab aja.
Okay. Anyone just turn on your mic and just give an answer. Oh, I see.
Oh, I see. We need permission to on the
Yes,
mic
you need the
open.
host permission
Okay.
to turn on the camera. Okay.
Let me ask the committee to turn on the mic.
Yes. Okay. I just would like to have like sort of I need some interaction with the students. So what do you think? What is it that? Okay. Oh, are you guys able to answer now? Oh, it's okay if you cannot answer, just drop in the chat box. Okay. Just give a guess. What is the cell?
Okay, everyone, you can check
There is no right
in the
and there is no
box.
wrong. You just can give an assumption of that. Okay. Okay, what do you think inside the yellow? I mean, we commonly take our urine specimen inside that bottle, the yellow bottle. So what is inside in the yellow bottle there? Is there any answer? Who would like to give a try? Okay. So since I'm not sure whether they are allowed to give an answer or not. They are allowed, right, Mr. Chairperson? Because I still didn't see any answer so far. Okay, it's okay. Let me continue. All right. You can stop me in between the session if I did not notice any question, yeah? All right. Okay. So this is the objective of my presentation after this. I hope in the end of the session, the learner will be able to define what is cancer, state etiology, risk factors of cancer, and different types of treatment. I would say that the best person to give the talk about treatment is actually the medical doctors. However, I believe that most of us here are coming from the background of allied health students. So I'm just sharing my experience and readings here. Okay. So next, learning outcome will be discuss appropriate nursing care plan for patients with cancer and the discharge plans for patients with cancer. And lastly, I would like to share how we apply evidence-based practice in cancer care in Malaysia setting. So what I'm sharing is actually locally performed by some of us, the academician and the researcher in Kuliah of Nursing IIUM. We just limited to our setting only. Actually, there are extensive research out there in Malaysia to actually tackle, to reduce the cancer incidence in Malaysia setting, okay? So what is cancer, as mentioned by Dr. Brian just now? And it is something that from a normal cells, it transforms into tumors. So what you see just now is actually the real cancer cells. That is my cells actually coming out from my endometrial lining after the doctors, the oncogyne team perform hysteroscopy, and that is the cancer cell that they carried from my uterus lining, and later on they sent to the laboratory for further analysis. I mean, Dr. Brian already informed you what are the type of analysis being performed to detect the cancer. Okay, so that is what you actually seen just now in the beginning of the lecture. There is a real cancer cell, whereby from normal cell it turns into tumor cells, and sometimes it go into multi-stage process that generally progress from precancerous lesion to a malignant tumor. So in my case, the tumor, there's a lot of tumor cells. If you can see, all the yellow water is full of tumor cells from small to big size. So it's actually still early at the early stage of cancer. That is the sample. So how it happens, the etiology. So we believe that usually we commonly say that once you have the genetic factors and it goes with the interaction with the external agent. So basically, like if you come into contact with physical carcinogens, like exposing yourself too much with the ultraviolet or ionizing radiation. I mean, you've been working in the asbestos or like the asbestos industry, and then you were exposed with tobacco smoker, particularly you have if you are residing with family members who is smoking, is quite dangerous. And okay, make sure after this, if you want to get a partner, ask first question, are you smoking or not? If smokes, please ask him or her to stop smoking first, okay? All right, and then it could be I mean they happen also when there is come into contact with biological carcinogen. For example, like viruses, bacteria, parasites, infection. Okay, so next, what is the risk factor? As I mentioned earlier, commonly genetic, gender, and however, this is the non-modifiable. The one that we can change right now is the modifiable, meaning that if you know that in your genetic, your heredity, like your auntie, your uncle, your grandparents, your mom or your dad is having cancer, or cancer already diagnosed with cancer, or they have family members who has at the cancer risk as well, you can modify your lifestyle to apply more healthy lifestyle. So indeed, when I was diagnosed with endometrial carcinoma, I'm a cancer patient by myself. So that's the reason I'm willing to give the sharing, because I can speak through my experience. I was an active person and I really take care what I eat. And people start asking me, you are the one who always jog every day. You really pick a certain type of food. I do cheat, but most of the time I'll cook myself, and yet you encounter cancer. So people are wondering, even my family members, my friends, so I will say that my strong factor is the genetic factor, because my late dad passed away due to cancer as well. So you can see here, once you have the genetic factor, you better take care of yourself. All right. So at the same time, if you have severe infections like H. pylori, HPV, Hep B, Hep C, Epstein-Barr virus, all this will actually will get you prone to develop cancer. So take care. If you have early symptoms, early warning signs, do not hesitate to get immediate care. So treatments vary. I mean, depends on the types of cancer. And of course, it needs multidisciplinary team to care for one patient. It's not only the role of a doctor to take care of a cancer patient. So I can't mention everyone in the healthcare industry, because I believe that whether you deal with the patient directly or indirectly, I believe that everyone is important, from the breast surgeon, radiologist, pathologist, oncologist, specialist, nurse, dietitian. They have made a lot of significant role in particularly in handling the symptomatic appearance that the patients complain, and then for nurses do a lot of supportive care and psychological care. And the recent trend highlighted in a lot of research is to take into consideration about spiritual care, particularly when we got to know that patient is going to have a terminally ill in the advanced stage in particular. Okay, at the same time, it requires also patient education, whereby we need to improve therapeutic communication and empathy. You know, the most important thing is that when you meet with a cancer patient, let them share what do they feel. Be a good listener. Not necessarily for you to solve their problems, actually. They only wish to have someone who could listen to what they have been enduring, because having cancer is not easy. Okay, and at the end of the day, why we need all this treatment from the medical side, from the laboratory point of view, from the radiological point of view, from the dietitian, from all the spiritual element, is because we hope that our client can make good informed decision making. And in the end of the day, even though you're having cancer, it doesn't mean the end of your life. We are actually quite advanced in our cancer care in Malaysia, and we hope that our cancer patient can improve their quality of life. And I believe I have another student here, staff nurse Nurzaini. She's an oncology nurse from Sultan Ahmad Shah Medical Center. And I believe that my undergraduate students are also here to listen to this session. Thank you for your time, even though they are in their they are actually in their mid-semester break right now. So the picture I'm showing here, this is an evidence base. I always inform my student, whenever you want to do an assignment or you are going to do your FYP project, please read clinical practice guideline. Give a habit of reading the clinical practice guideline, because this is a gold standard reference that being practiced in our Ministry of Health setting, so that we know what is the current trend in our care, in the cancer care particularly. All right. So when we talk about treatments, usually it focus on surgery, radiotherapy, or in combination with systemic therapy like chemotherapy, hormonal treatments, or targeted biological therapy. For myself, I have this experience of undergoing surgery, and I've been actually undergoing hormonal treatments as well during my, because you know, cancer has different treatment, as I mentioned earlier. The treatments is actually varies, and so this is what I've gone through. And then, so basically, how do nurses fit in the oncology care? So basically, if you are a nurse, so sorry because I didn't prepare your role for other nursing student, non-nursing students. So as a nurse, you play important role in symptomatic control, in the intraoperative care, and patient education or discharge planning. I would say that most of us, we are lacking in this angle, in the patient education or preparing the client for discharge. We did, but most of the time, it's not really in a formal way. We do it indirectly, usually while we are preparing or we are doing our procedure. So this is how actually nurses fit in the industry. We coordinate within the multidisciplinary team. So in the end of the day, we don't want our patient to lose to follow up, and they are able to enjoy quality of life even though they are living with cancer. This is the most important things. Okay, I'm sharing you my experience. This is my symptomatic appearance, whereby I'm having bleeding. So when there is a non-stop bleeding, one day like 10 pads soak with all this, if you can see, this is actually a blood clot. Okay, when there is cancer taking place at your endometrial lining, the erosion, the wear and tear process takes place very fast. And I would say that my hemoglobin, I am a regular blood donor. Just imagine if my hemoglobin usually at 14, 14.3, it drops up to 6.7 during my cancer journey. So right now I cannot donate blood anymore. So I'm still in my recovering stage. So this when the bleeding couldn't be stopped anymore, and then the doctors advised me, and it's not easy. It took me 6 months to decide for laparotomy or hysterectomy. My hysterectomy went through laparotomy type of surgery. This is the surgery things. And before we come to the stage of deciding the surgery to take place, they need to confirm whether it's a true cancer. And yes, they send this specimen to the lab, and you can see this is the bigger one, the bigger cells, and this is small, tiny things in residing in my endometrial lining. So you can see a lot more. In fact, I think there's more than 4 bottles, if I still remember well. So the bottle is full with all the specimen, and this already, from the appearance, we can say that it's okay. It looks like cancer cell, but nevertheless, they were sent to the lab for further confirmation. And when I've got the results, it's clearly said that it's a cancer cell, and the best things to do right now is go for surgery and take off everything. So to make myself safe, the rest of the organ, the reproductive organ is being taken away, so that why this measures is being done or performed by the oncogyne team is that they don't want any remaining cells that would invade the lymph nodes and metastasize to the other parts of the body. So that's the reason I really wish all of you here who listen to this session today, please remind everyone out there, if there is earlier symptoms, do not hesitate to get further treatment, because sometimes surgery can save life, or is there any intervention like scopic surgery. There's a lot of mechanism through scopic mechanism, through robotic surgery. In my case, it was a laparotomy because they need to explore more so that there is no invasion. So I would say that early recognition of symptoms. So my early recognition of symptoms is the bleeding, and it can goes to early save of your life actually. All right, so this is the surgery process that I will go through to actually save myself from letting the cancer spread to all the body. All right, so curing the cancer, as I mentioned earlier, keyword of success is early detection and effective systemic treatment. So the medical or the oncology team will determine what types of cancer or chemo or hormonal sensitivity, the tumor bulk, microscopic or clinically detectable, as mentioned by Dr. Brian earlier, because each cancer cells, they are sensitive toward certain drugs or medication. Not all cancer is treated with the similar drugs, okay? So our nurses' role, what is our role here? We will ensure that all the preparation for the client for necessary procedure, either diagnostic, surgery, or pharmacological intervention at pre, during, and post-care run smoothly, because we are actually the one who take care of the patient in the ward. So we coordinate with a lot of healthcare professionals. So this is our important role, in fact. So why certain patient receive chemotherapy, why certain patients did not receive chemotherapy? Again, for example, in myself, I was diagnosed early. Alhamdulillah, I was at early stage, so I don't have to go through chemotherapy. However, if the patient is diagnosed at a later stage, like stage 3, stage 4, and again, chemotherapy, the protocol also differed by type of cancer. So it would depends on the staging, and it would depends on the cancer, and how basically the concept, how it actually kills the cancer is through damaging the DNA and RNA through apoptosis or necrosis. Apoptosis meaning that it makes the cancer cell kill themselves, or necrotic, it shrink the cancer cell until it disappears. Okay, so let us enjoy this video so that you can at least see, have an idea what is cancer is all about.
Dr. Christopher Winkler. I'm the owner of Suffolk Veterinary Group, Animal Wellness and Laser Surgery Center.
Okay. Can you see the video, guys?
During World
Yes, we
War
can
I,
see,
one of the
Doctor.
horrors
good.
of trench warfare was a poisonous yellow cloud called mustard gas. For those unlucky enough to be exposed, it made the air impossible to breathe, burned their eyes, and caused huge blisters on exposed skin. Scientists tried desperately to develop an antidote to this vicious weapon of war. In the process, they discovered the gas was irrevocably damaging the bone marrow of affected soldiers, halting its ability to make blood cells. Despite these awful effects, it gave scientists an idea. Cancer cells share a characteristic with bone marrow. Both replicate rapidly. So, could one of the atrocities of war become a champion in the fight against cancer? Researchers in the 1930s investigated this idea by injecting compounds derived from mustard gas into the veins of cancer patients. It took time and trial and error to find treatments that did more good than harm. But by the end of World War II, they discovered what became known as the first chemotherapy drugs. Today, there are more than 100. Chemotherapy drugs are delivered through pills and injections and use cytotoxic agents, which means compounds that are toxic to living cells. Essentially, these medicines cause some level of harm to all cells in the body, even healthy ones, but they reserve their most powerful effects for rapidly dividing cells, which is precisely the hallmark of cancer. Take, for example, those first chemotherapy drugs, which are still used today and are called alkylating agents. They're injected into the bloodstream, which delivers them to cells all over the body. Once inside, when the cell exposes its DNA in order to copy it, they damage the building blocks of DNA's double helix structure, which can lead to cell death unless the damage is repaired. Because cancer cells multiply rapidly, they take in a high concentration of alkylating agents, and their DNA is frequently exposed and rarely repaired. So they die off more often than most other cells, which have time to fix damaged DNA and don't accumulate the same concentrations of alkylating agents. Another form of chemotherapy involves compounds called microtubule stabilizers. Cells have small tubes that assemble to help with cell division and DNA replication, then break back down. When microtubule stabilizers get inside a cell, they keep those tiny tubes from disassembling. That prevents the cell from completing its replication, leading to its death. These are just two examples of the 6 classes of chemotherapy drugs we use to treat cancer today. But despite its huge benefits, chemotherapy has one big disadvantage. It affects other healthy cells in the body that naturally have to renew rapidly. Hair follicles, the cells of the mouth, the gastrointestinal lining, the reproductive system, and bone marrow are hit nearly as hard as cancer. Similar to cancer cells, the rapid reproduction of these normal cells means that they're reaching for resources more frequently and are therefore more exposed to the effects of chemo drugs. That leads to several common side effects of chemotherapy, including hair loss, fatigue, infertility, nausea, and vomiting. Doctors commonly prescribe options to help manage these side effects, such as strong anti-nausea medications. For hair loss, devices called cold caps can help lower the temperature around the head and constrict blood vessels, limiting the amount of chemotherapy drugs that reach hair follicles. And once a course of chemo treatment is over, the healthy tissues that have been badly affected by the drug will recover and begin to renew as usual. In 2018 alone, over 17 million people worldwide received a cancer diagnosis, but chemotherapy and other treatments have changed the outlook for so many. Just take the fact that up to 95% of individuals with testicular cancer survive it, thanks to advances in treatment. Even in people with acute myeloid leukemia and aggressive blood cancer, chemotherapy puts an estimated 60% of patients under 60 into remission following their first phase of treatment. Researchers are still developing more precise interventions that only target the intended cancer cells. That'll help improve survival rates while leaving healthy tissues with reduced harm, making one of the best tools we have in the fight against cancer even better. Have you ever wondered why, after many years and extensive research, we still haven't cured cancer? Take a closer look at this particular medical challenge with our deep dive on the quest for a cure.
All right. So basically, that's how cancers work. All right. Hold on.
Udah pada keluar, Cok.
Okay, sabar-sabar.
Udah 223.
All right. Okay. So as you already watched the video just now, I think some of you is not muted. I hope you can mute yourself. All right. Okay, this is the classification of cytotoxic drugs. The first class is DNA damaging. There are a few types of DNA damaging, like alkylating agents, where it interferes with DNA synthesis and causes strand breakdowns, platinum compounds, antimetabolites, and there are a few types of category like folic acid antagonists, pyrimidine antagonists, arabinosides, purine antagonists. So basically, it damages the DNA. So that is the classification of the cytotoxic drugs under the DNA damaging. Okay, next. For DNA repair inhibitors like epipodophylotoxins, cytotoxic antibiotics, so the mechanism, it is unwinding and uncoiling of the supercoiled DNA, or it perform intercalating or intercalation, adjoining the nucleotide pairs on the same strand of DNA by inhibiting the DNA repair. Okay, for antitubulin, I believe you already watched the video just now. The drugs classified into vinca alkaloids and taxanes, whereby it, sorry, typo over there, it binds to the tubulin and inhibits the microtubule formation, like the one that you already saw in the video just now. So it prevents the assembly into the microtubules. Okay, this is the example of chemo protocol for breast cancer treatment. Don't worry, you don't have to memorize everything. This is just nice to know how the staff nurses, after receiving the prescription from the doctors in charge, the oncologists, they usually nurses will need to prepare all this medication. So this is what we call the protocol. What should be given first, what we should be given next. Okay, that's the reason the expenditure or the cost for chemotherapy is very expensive. So we need to make sure that our client do not lose to follow up, because you know the preparation of the drugs is actually very costly, and if you never come, you never turn out, we are actually wasting the preparation process. Okay, this is the example of chemo protocol for colon, sigmoid, or colorectal cancer treatment. Okay, this is the example of chemo protocol for ovary, lung, or peritoneal cancer treatment, which named as carboplatin paclitaxel protocol. And this is BEP protocol, chemo protocol for testicular cancer or germ cell tumor treatment. And then this is another chemo protocol for breast cancer, the AC protocol. And usually, prior to delivery of chemotherapy, patients will need to sign this consent form, and usually the nurses will become the what we call the witness on the side, because it is important. In the first place, as I mentioned, the aim of the goals for cancer treatment is that they are informed. They are actually well informed, can decide wisely after given the correct informations what they need to go through. So once they understood the explanation given by the oncologist, what are the side effects, how it will be running through. So once understand, they can tick the boxes and then sign by themselves. Okay, this is the example of the chemo drug preparation. The chemo drug preparation is usually comes from the pharmacy department, and the nurse only administer, because whatever the ingredients inside here is actually prepared by the pharmacist. Okay, So this is how it looks like in terms of the preparation. Sometimes 2 drugs run at the same time. Sometimes single drug runs at the same, only single drugs run at one point of time. Okay. As you also listen to the YouTube video just now, the common side effect, nausea, vomiting, hair loss, myelosuppression or bone marrow suppression and immunosuppression. Therefore, if you notice that when there is bone marrow suppression, when there is depletion of red blood cell, the platelet drops, the hemoglobin drop, but if the white blood cells keep increasing, it's actually quite worrisome because, you know, when during the chemo, patients can turn up, become anemic, and therefore, patient easily feel fatigue. That is the reason why actually during chemotherapy, patients usually appears fatigue, and sometimes it's hitting the layer of the mucosa membrane. So that's the reason most of the cancer patient during chemotherapy, they might experience, commonly they will experience mucositis. And for vomiting, how to limit it? We can control by metoclopramide, ondansetron, organisetron. This is type of antiemetic drug. And the rest, number 2, number 3, number 4, number 5, we need to perform relevant nursing care intervention that I will share with you later on. And sometimes those patients who undergone chemotherapy for a lot of cycles, for many cycles, sometimes they have a severe side effects. This is a severe side effects like cardiotoxicity, neurotoxicity, nephrotoxicity, sterility, secondary malignancy, commonly induced by the drugs that I've given the example over here. So therefore, usually all chemo patients, they come under close supervision of the oncologist in charge at the clinical side. So that all these severe side effect is not actually not treated. So that's the reason why we need our patient not to lose to follow up so that we can monitor them closely. Okay. So next therapy is endocrine therapy. So in my case, I've used to on with OCP, or oral contraceptive pill. So the purpose of endocrine therapy is actually to block the effects of estrogens and androgens, which may act as growth factor. So sometimes excessive estrogen and progesterone level could induce breast cancer and cancer as well. Oh, for example, the other example is aromatase inhibitors. It block the conversion of androgens, which can cause prostate cancer. And sometimes gonadotropin releasing hormones and agonists, it could lower levels of circulating androgens and androgen receptor blocker. So sometimes when you go through the endocrine therapy, even though it is for treatment, but at certain times it could actually induce cancer itself. So this is actually the drawback. That's why when we talk about the success of medication or pharmacological approach, the success will be between 95% to 99%. However, the failure rate is actually range between 1 to 5%. So if you are lucky enough, you will be in the threshold of success. But if you're not lucky enough, you will be in the threshold of the failure rate. So whatever it is already fated. Okay, if you were diagnosed with cancer, initially you will question why me, but in the end of the day, you will see it's actually Allah's plan or the God's plan. So we need to follow what has been planned for our Almighty in our way. All right. So the next is biological therapy listed over here. Number 1 to number 9, interferon, interleukin, thyroxine, anti-growth, and CD20. Protease inhibitors, hemopietic growth factors, and myeloablative therapy. Okay, so radiation therapy. So how do radiation therapy, as I mentioned earlier, if you're still diagnosed at early stage, you will not need radiation. You will not need, sorry for the typo over there, you will not need chemotherapy. So basically, how how radiation is delivered. It delivers energy to tissues, causing ionization and excitation of atoms and molecules. And what type of radiation therapy is there? We have teletherapy, brachytherapy, and systemic radionuclides. So usually radiotherapy is actually primary modality to stop the progressing of these cancerous cell from advancing to another stage, or it could be adjuvant to the primary surgery. For example, sometimes for later stage of cancer, patients still receive radiation therapy, but it's only for adjuvant. All right, so let us watch this video.
Radiation therapy is a type of treatment that uses beams of intense energy to kill cancer cells.
Approximately 60% of all cancer patients receive radiation at some point during their disease course.
Talking through your treatment options with your oncologist is a good place to start. If radiation therapy holds promise for your cancer, you'll next want to meet with a certified radiation oncologist. Come prepared with a list of your questions and concerns.
So in my first meeting with a patient, typically we go over the stage of cancer. We'll talk about where the cancer is. Many times I'll review a PET scan or a CT scan or sometimes MRIs with the patient so they can sort of get a visual picture of what's going on in their body.
If radiation therapy is prescribed, a second appointment will be made so the radiation oncology team can precisely create your treatment plan.
You're generally getting into the treatment position, you're getting a CT scan, and you may get some tattoos or some stickers marked on your body that the doctors will ask you to keep in place for the duration of the radiation treatment.
For patients whose cancer has spread to the brain, additional preparations are also made.
In those situations, we do make a mask that goes over the patient's head that will keep you still during the radiation treatment.
Following the mapping session, the radiation therapy team designs a treatment plan and schedule tailored to your needs. Thanks to new and better technologies, radiation therapy has become more targeted over the years.
Because of these advances in technologies, we are noting our patients having much less side effects from their radiation treatment. The most common side effect from radiation is really fatigue or tiredness. And that happens during your radiation treatment course, but it resolves pretty quickly.
Keep in mind, however, that side effects can vary widely from patient to patient, and your own experience will depend on a number of factors.
It will depend on how large the area is that is receiving radiation. It will also depend on if you're getting any chemotherapy or immunotherapy or targeted therapy during your radiation. But typically radiation is fairly well tolerated. And I will say that our supportive care has really come a long way over the years, and we have great medications that can help mitigate the side effects of radiation therapy.
Some patients may need pain medication to help them relax during treatment. All patients having radiation treatment are advised to drink plenty of fluids while they're undergoing therapy.
Because radiation can suck the moisture out of your body and make you feel bad if you're not replacing that fluid. So staying well hydrated is really important.
The radiation oncology team will schedule follow-up appointments several weeks after you finish treatment to monitor your progress and address any side effects you might be having.
All right. So, what are the side effects? As you already listened, I suppose, in the video, the impact of the radiation therapy is that in acute stage, it might cause you anorexia, lack of appetite, nausea, malaise. Malaise is actually feel tired, but not that severe. Mucositis, esophagitis, diarrhea, alopecia. Alopecia means loss of hair, and myelosuppression. However, in later stage, because radiation is not only used at one point of time only, sometimes there will be repeated sessions of radiation. So it might cause your skin to become ischemic or ulcerated, and the bone can become fractured, mouth To severe extent, it can cause xerostomia and bowel stenosis or fistula, bladder cystitis, vaginal dyspareunia, lung fibrosis, the hardening of the lung, heart pericardial fibrosis, the heart as well can be hardening. And then the central nervous system, it could cause myelopathy. Gonads, it can also induce infertility, and the procedure itself can cause secondary malignancy. So what I'm trying to say here is that once you've got cancer, even though the treatment is safe, but somehow it could trigger another second malignancy. However, I believe that all the healthcare professionals, the onco team, they will do their best to make sure that the second malignancy doesn't occur. But if it occurs, I would say that is a blessed in the disguise episode. Okay. So this is the other emergency situation that this is under the medical team responsibility. So I will not touch, I will just give you the highlights. What is the oncology emergency situation that needs the medical team responsibility? Okay. And this is the important role that nurses can play. Nurses, we have palliative center in Kuantan at Hospital Tengku Ampuan Afzan. So why we give palliative care? Because we know that cure is no longer possible. So we hope that with palliative care, the cancer patient, they can live longer and actually enjoying the quality of life. And at the same time, we try to help them to relieve the tumor symptoms, particularly most is the pain, because cancer patient is actually living in pain. And how it can be done? Sometimes with the use of chemosensitive drugs, and sometimes using the anti-emetic drugs. And certain patient, they will opt for chemo drugs. Certain patient will not need those things because they think they wanted to go peacefully. To go meaning that they just would like to live their life peacefully for what is remaining of the years. And this comes the role of nurses to give a compassionate care, particularly to give a very good, therapeutic communication that is actually address the needs of the clients, their worries, and apply the empathy method throughout nursing care intervention. And taking into consideration the spiritual care, perhaps in the future, we need to have chaperone or religious officer arrangements to visit our cancer patient. This is actually what are recommended in the research paper. And pain control. So the other approach for pain control, like I mentioned, sometimes patients refuse to receive any chemo drugs anymore because they just wanted to live their life to the max. So sometimes there will be non-pharmacological approach, and there is latest evidence saying that using VR, virtual reality, is actually helpful to reduce the pain among patients. Okay. So two way of determining the effectiveness of the treatment. Subjective, meaning that once your patient said they have reduced pain or they eat better, they feel less fatigue, then meaning that your approach is successful. The objective, complete disappearance of tumor. And again, this is actually only determining by clinically or radiologically by 50%. If more than 50% the tumor is still there, meaning that it's not palliative stage anymore. Okay, this is the picture of one of the doctor in Kuliah of Nursing who have collaborative visit with the NGO, Majlis Cancer National East Coast team, and they paid a visit to the palliative ward in our Ministry of Health setting, Hospital Tengku Ampuan Afzan for Salam Aidilfitri 2021 donation. Okay, can I have like 5 minutes break before we go to nursing care plan? Is that okay?
Okay,
All
it's
right.
okay, Dr. Raf.
Okay, so guys, you can go for refreshment for a while. So I have a break like 3 to 5 minutes like that, so that you guys can start fresh.
Okay, for all the participants, if you need a break or maybe you have an idea to ask or anything you will be
Yes,
sharing with the Dr. Siti, you can drop into the chat box below, okay?
Kok menambah? Okay, before I proceed with the skincare plan, I hope all of you students, you can try to search for Padlet, padlet.com. Sorry, typo over there, padlet.com. Okay, try to explore padlet.com. Meanwhile, before I proceed, okay. Let me share my screen first so that you can see. You can QR scan the padlet.com. Okay. Over here. Okay. All right. I really hope by the nursing students online, you can scan it first. Or you take a picture first and try to scan it. Right. Okay, can you raise your hand? How many of you nursing students? I just would like to see hands.
Okay, nursing student, can you raise your hand?
Yeah, raise your hand, please.
Dr. Siti wants to know from the Poltekkes
Don't
Kampus
be shy.
Mataram. And student of Dr. Siti from Malaysia, you can raise your hand.
Or you can chat in the box your name. Hi, I'm nursing student. If you're a nursing student, just chat in your box that you are a nursing student. Ah, good. Yeah, hi, I'm nursing student. Yes, I need to see more hands in the chat box. I'm not sure. From Indonesian part, is there any nursing student?
Okay.
Okay, good.
Yes.
Come, I need to see more hand. Come on, my nursing student over there, Malaysia and Indonesia, where are you guys? Don't be shy. Come on.
Yeah.
All right. So I'm glad. All right. I hope to see many more hi here in the chat group. Because just now I saw the numbers is 400 plus, now become 200 plus. All right, no worry. We continue our session. Okay. All right. So I give you one scenario. Okay, this is nursing care plan. It is very important to develop nursing care plan that is focused on the patient, or we call it as patient-centered or family-centered approach. So this is according to Consulo, Suhonen and Karambelas 2019. It's important that you embedded the evidence base, particularly addressing all the client needs so that they feel valued, because client should need, and the client need to have all this feeling, being respected, being informed, being cared and communicative and supportive, being confirmed, being cared religiously and spiritually, and having a sense of belonging from the family members throughout their journey. So meaning that all this element is actually important to be embedded during the nursing care. So I've listed important nursing diagnoses based on NANDA 2018, the actual pain, disturbed body image, ineffective protection, nausea and vomiting, deficit knowledge. Meanwhile, potential risk for venous thrombosis, risk for chronic functional constipation. And usually this is the format that we use. We state the nursing diagnosis, then we relate it with the causal factor and evidence by the sign and symptoms characteristics. Okay, this is the scenario I give you. I feel grateful because Dr. Brian also did mention about breast cancer just now, which aligned to my presentation. So Mrs. Lana, 50 years old, is planned for mastectomy due to invasive carcinoma. She arrived in the onco-gynae ward with her sister at 8 a.m. and the surgery is scheduled the next day. You are the nurse in charge of the AM shift. You started intravenous access for her, measured the vital signs and performed necessary admission assessment. During the assessment, Mrs. Lana informed you that she's worried about the surgery since it's the first time and whether reoccurrence might happen. She's also concerned about what she looks like after mastectomy and how to take care of herself. So what would be the nursing diagnosis appropriate for her? So in this case, the appropriate nursing diagnosis will be deficient knowledge related to lack of exposure to relevant information about cancer diagnosis, treatment, symptoms, evidence-wise that the patient verbalize her worries. So your duty is that we hope that your patient verbalize understanding and less worry. And this is what you should do. You need to assess patient baseline knowledge, health literacy, and their readiness to learn. Because if you are too stressed, they can't receive the information that you are going to teach them. And when you know the literacy level, you know how to actually manage the literacy level with the content that you're going to deliver, and make sure you provide clear, concise explanation. Avoid using medical jargons or complex information, and please use medical aid, usual aid, so that it can simplify medical information. Sometimes using videos will simplify complex instruction. You teach specific self-care procedures that patient would like to know, like how to control nausea, and then encourage patient to ask questions, engage the family member, and you need to evaluate whether your intervention is effective or not, and then provide list of reliable resources. So in the end of the day, you need to evaluate whether it's successful or not by if your patient verbalize, they understand, or they can perform the necessary self-care. Okay, the next procedure, anxiety related to changes in appearance, evidence-based by patient verbalizing her concern about her body image. So we hope that your patient will verbalize less anxious. So assess patient's perceptions about surgery and anticipated results. And the support system, assess client side and symptom of anxiety. For example, they told you that they cannot sleep, so that you can collaborate with the medical team if necessary. And then make sure you orientate the client to the staff in charge, encourage patient to verbalize their worry, and then reinforce whether they understand or not what the physician explained to them, and clarify any misconception, and then instruct client to perform relaxation technique. And lastly, this is the last resort. If not, the anxiety never goes, perhaps you need to discuss with your doctor to whether to prescribe anti-anxiety or not. So we hope in the end of the day, the patient will verbalize more relaxed and ready for surgery. And the next scenario I'm preparing you here is after the surgery. So Mrs. Lana already completed her mastectomy and sent to the onco-gynae ward after being stabilized at the OT recovery room. She was transferred to the ward with IV access at the right hand, drainage from the surgery side, CBD in situ, and patient control analgesia. Upon awakening from her sleep, you encourage her to ambulate and taking her meal. However, she complained of slight pain on at her last breast area and loss of appetite. So what will be the nursing diagnosis you can develop for her? So over here, I provide pain related to treatment, related treatment side effects, evidence-based that patient verbalized pain score of like maybe 3, more than 3, 4, 5 like that. And your goal will be to reduce patient's pain level to less than 3, and patient know how to apply non-pharmacological technique, for example. And the most important thing is assess the pain characteristic for location, intensity, qualify, duration, prescribe analgesics, because if major surgery, never, your patient definitely will be discharged with some PCA. And you need to encourage patient for relaxation techniques like deep breathing, guided imagery, virtual reality. The latest by evidence base, it shows that VR is very helpful, and evaluate the effectiveness of the intervention. And we hope that your patient will mention to you or verbalize to you that her pain is reduced to 2 at least. Okay. Next, I give you the scenario. Sometimes patient might also loss of appetite related to the procedure after the surgery, evidence by verbalize of not interest to eat. So what is your goal? At least your patient verbalize he or she could take one type of food that she really preferred. So what you can do as a nurse, we are not taking the role of dietitian over here, but we still need to prepare the intake and output so that we can see what did our patient receive. If patient is not on tube, encourage high protein, high calorie meals, and then offer foods with strong flavor or preferred taste, particularly if your patient after surgery need to go through chemotherapy. Definitely sometimes the taste will be reduced. Okay, then coordinate with a dietitian to develop personalized nutritional plan, provide small frequent meals rather than large meals, encourage family involvement in meal preparation, and discuss option or appetite stimulant. This is the last stage, and we evaluate whether patient managed to finish her meal or not with the assistance of family members. Okay, this is the potential risk of infection related to indwelling catheter at the site, because as we know, when patients is actually after the surgery, there's a lot of catheter on their body. So we hope that patient will be free from wound infection during hospitalization, as evidenced by absence of redness, heat, swelling, and increased pain at wound area. So what will be the intervention? Assess for and report signs and symptoms of wound infection, monitor for and report persistent elevation of white blood count, perform hand washing, apply sterile technique, anchor wound drainage, and administer antimicrobial. So this is the thing that you can do to reduce the infection, in the hope that during the hospitalization, patient is actually free from any infection. Okay, guys, shall we do some discussion? Upon completion of mastectomy, Mrs. Lana need to undergo several cycles of chemotherapy and radiotherapy. Most of the time, she will experience nausea and vomiting, loss of hair, and dry skin. Okay, I will minimize my screen sharing so that we can open the Padlet. I'm not sure how many of you manage. Can you see this?
Mr.
Okay.
Siti, I'm
Yeah.
sorry, we still have 5 minutes left.
All right, sure. Okay, so I skip that part. Okay, I will skip that part. I just continue. All right. Okay, so this is what I wish to share with the Indonesia counterpart over there. What did we do in discharge plan in Malaysia? So as I mentioned earlier, it's important for having a proper discharge plan so that our patient not lost to follow up, supportive treatment, including rehab and lifestyle modification. And our nurses' role in rehab plays like relationship forming, coordinating, follow up. This is where our role is very important. Okay, this is the picture how one of our staff, Dr. Rosnani, she has this strong connection with the patient of breast cancer survivor. They sometimes organize event, they went for picnic and share story. And this is how the relationship is formed over here. And for example, for me myself, how do I contribute towards my community support resources? I do give some sharing on coping with cancer. I write online ebook on reproductive cancer I also collaborate with MACNA, Majlis Cancer National, by opening my own elective course. And this is actually how we do our collaboration. We do have research, we perform program, we do copyright. So this is actually the event, the community engagement that we managed to create in IIUM. For example, this is the elective program of my student, the elective program that I offered to my undergraduate student on breast cancer awareness. So we managed to bring this elective course to be finalists. We are not winners, but we are in the second or third runner-up like that, if I'm not mistaken. And the other flagship, led by Associate Professor Dr. Siti Mariam, we managed to win the International Green Gown Award for SDG, IM flagship level. And during one of the activity that we bring up for the community engagement is actually deliver a podcast on breast self-examination among breastfed mother during the World Breastfeeding Week. And you can visit this YouTube for further, if you wish to see the podcast further. Okay. And this is the elective course that I've managed to open up for 5 series so far, and coming soon 6 series. And these are the talent output. I have so far 5 cohort students that create awareness on breast cancer. And this is my FYP students who did a research on breast cancer awareness or VR. Okay, this is the output of myself and working together with my FYP students. We produce, and some of them is actually indexing, and soon one of my paper will be in Scopus. And this one we present at international level. And my recent presentation is actually a systematic review on awareness on breast cancer and breast self-examination practice. And this is what I wish to address over here. I hope that one day my friends in Indonesia, perhaps you guys could collaborate and do research on VR, because it's proven it could reduce anxiety among cancer patients and pain. And this is the evidence to support this justification. And I would like to take this session platform to acknowledge my collaborators and individuals indirectly helping me in for today's preparation. And in the conclusion, cancer treatment varies according to the system. However, the nursing care aspects did not differ much because prioritization is made based on symptoms or complaints from the patients. So it's important for nurses, we need to get the subjective information and support it with objective evidence during assessment, so that in the end of the day, we could develop proper nursing care plan for our cancer patients. This is the reference. And with that, thank you. Okay, is there any question from the floor?
Thank you so much, Dr. Siti. You deliver such an impactful and heartfelt presentation and sharing your personal experience with the cancer surgery, not only to encourage, but also inspire everyone in this room also. So, oh yeah, we have someone with the raised hand. I would like to invite Fadila. you can ask directly to Dr. Sidi.
Yes, please, Fadila. Are you mute, Fadila? We can't listen to the voice.
Yeah, Fadila, you need to unmute first.
Yeah. Oh, still.
Doctor?
Yes.
Yeah, okay, Fadila.
Uh-huh.
My question is that, as you mentioned before, that we know one of the drugs using for chemotherapy is the cytotoxic antibiotic, right? So my question is that, is there any possibility to get the liver damage during the chemo, and how much the percentage those problem can be happen to the
Come again?
patient?
Can you repeat the question?
Is there any possibility to get the liver damage during the chemo?
Liver
And how much,
damage, liver damage.
yeah, and how much
Okay.
the percentage?
All right. So as I mentioned before, liver damage it is a risk. The risk that will happen if there is a poor monitoring. So the purpose of chemo is actually to kill the cancerous cell. At the same time, each time during the cancer session, the blood is withdrawn from the patients before and after so that the doctor can monitor. So if the situation will progressing towards liver damage, they will detect earlier. It's in Malaysia, I will say that the situation is actually under control by the medical team. So to have liver damage directly just from one cycle to cycle is hardly happen. That's if you ask me what is the percentage, I can't give you the exact figure because the percentage or the chances of everyone to get the severity stage or toxicity depends on how the stage of the cancer, because if someone who receive chemotherapy at later stage, the chance might be higher. So I'm so sorry for the details of percentage, I cannot give you the exact figure, but I would say that the chances to develop liver toxicity is actually hardly happen if it's not if it's monitored properly. In Malaysia, the nurses are the key person because when we got the result, usually the nurses who receive the result from the lab, the nurses would need to inform to the doctor. And usually at the results level, there's the abnormal range. So if you notice that the abnormal range is actually presented in your patient, you will directly straightly aware and make the doctors informed. So this is the important roles of nurses. That's why I will always say that we as nurses, we are coordinators. We are coordinators among the healthcare professionals. We coordinate with the lab, and in this case, I give the example. And if you notice, the readings is quite abnormal or slightly high from usual, you are the one who is responsible to inform the medical doctor. I hope these questions can answer you, can satisfy you, Fadila.
Yes, thank you, doctor.
Welcome. Any more?
Thank you, Doctor. It's really insightful. But we still have a ton of questions, Doctor. But our time is limited. But later we will write down the question. I'll maybe sending to you the question and they
Sure.
got the answer.
All right, thank you very much. No problem. I'm scared I'm taking other time, other people's time.
Okay, thank you so much, Doctor. Before we end of our session, we would like to ask you giving them a closing statement, especially for nursing student.
Mhm. For nursing student, I would say that the keyword of success for you to endure in the profession is passion. You need to have passion, strong interest, and sincerity. Or with these key things, fundamentals or principles, you can become a good nurse. I always my advice is always simple: be a good person, no matter what you do. Be a good doctor, be a good nurse, whatever. Be a good non-healthcare professionals in the future. Because if you understand the principles of being good, you will watch out your steps, your manners, because you don't want to do harm to other people. So just be a good nurse and be sincere with what you are doing now.
Thank you so much. Be a good person, right? Thank you so much, Dr. Siti, for your insightful. Thank you so much for participation as a speaker in our Zoom meeting. Your presentation was outstanding and truly insightful, leaving the great impression on everyone. We certainly hope we have opportunity to meet you in person, Doctor. Maybe you come to Lombok later in the
Mashallah.
future.
Perhaps one day we gonna establish a
Yeah, we will invite you after this. Okay, once again, Doctor, thank you so much for sharing your expertise and valuable time for us. Thank you. We hope we see you later, Doctor.
Thank you.
Can you give applause to our speaker, Dr. CP? Yes, really insightful and really nice to see Dr. Siti with us. And we continue our section, our third speaker for today. In this first session, we'll invite Miss Jenny. Hello, Miss Jane.
Hi, good afternoon. Can you
Hi,
hear
good
me?
afternoon. Yes, your voice is audible, Miss Jane. Yeah,
Okay.
how are you, Miss Jane?
I'm fine. Thank you.
Sorry for waiting for a bit moment, right?
That's okay with me.
Yeah, we are from Poltekkes Mataram. We have a lot of students here, and we are so ready to hear your presentation. The title is Clinical Nutrition, Prevention and Management of Cancer. This session will explore how diet and nutrition can be powerful tools in cancer prevention and in enhancing patient outcomes. Without further ado, let's welcome Miss Jenny C. Furtodazo. The stage is yours, Miss.
Thank you. I would just like to share my screen.
Yes. So nice.
Oh, wait. Where is it? Okay, so can you see my slides?
Yes, you can see your slide, Miss.
Okay, so first of all, I would like to thank the organizer of the international webinar at the Health Polytechnic of Mataram, and the director of the Ministry of Health, I was not able, but the director of the Ministry of Health of Mataram, and also I would like to thank my colleague, Dr. Leila Africa, who was the one who invited me for this lecture. Thank you so much for the opportunity to be able to share with you my lecture for clinical nutrition for cancer prevention and management. So, are you seeing my slide already?
Yes, it's okay.
Thank you. Okay, so what are the learning objectives of our lecture for today? I understand that there are students and also healthcare personnel in the room. Is it correct?
Yes, doctor. Most of students are from Polytechnic and some of students from Malaysia.
Okay, thank you.
Mm,
Okay,
mm.
so these are the learning objectives for our lesson or lesson because I am a professor for today's lecture. Now, so first, we would want to define cancer and understand the pathophysiology and etiology of cancer. And then we would also like to enumerate the compounds, nutrients, and bioactive compounds with anti-cancer properties. Na, so from my lecture, you will also learn, and I will also share with you what are some of examples of food that are particularly with anti-cancer properties or food that can fight cancer. So I will also discuss the nutritional recommendations to prevent cancer, and then also explain the biological mechanism of action and evidences of the dietary compounds that will be discussed, no, on cancer prevention. And also, we would like the participants to gain knowledge on the strategies, no, or what we call as the nutrition therapy for cancer management, most especially in doing the nutrition therapy for cancer patients or the individuals who have already have diagnosed with cancer, and from the lecture of Dr. City are the ones who are undergoing the therapy like chemo, radiation therapy. No? So we're going to give discussion on how to manage the problems arising from these conditions. No, so I would also like to give acknowledgement to my colleague, Dr. Norma Hita P. Gordoncillo and Miss Jerica B. Suarez, who in one way or the other are part of the slides that I have utilized. No, their slides are borrowed. I have borrowed slides from their previous lectures. So first, let us discuss cancer. And I would like to share a video with you to discuss, no, this is from Job Education to discuss cancer.
I'm sorry, Dr. Jane. The audio is still not sharing this.
Wait. You cannot hear the audio?
Yeah, we still have a problem with the
Okay.
audio.
Okay. Wait, I'll just share it again. The video is about Filipina nurse who had cancer, no, and it was about her fight about cancer. Okay, wait, I'll just make sure that we share also the audio. Wait. So share screen, share sound. Yes. Can you hear the audio already? Hello? Can you hear the audio?
Not really.
Still not, cannot hear you.
No audio. Anyway, wait. You do not hear it. Why kaya? Anyway, let's just keep. I will just continue with the lecture and share the story with you. Okay. So, okay. Okay. Now, so this story, can you see my screen already? Okay, teka. I just need to share it with a slideshow. Okay, so this is online. So we have some technical difficulties, no? Okay, now so the video that I have just shown you is about a Filipina nurse who just had who had cancer of the breast, no? So she was diagnosed, and as a healthcare professional, she was able to experience and deal with the actual experiences of a cancer patient. Now, so when she was diagnosed, she had undergone mastectomy and then chemotherapy. And from the video, now we will see how positive she is with her fight against cancer. How was she able to combat all the challenges in life, no? We know that cancer is very very expensive, no? So it utilizes very expensive treatment like that chemotherapy and also the radiation therapy. But with this case, with the patient, no, you will see that from her story, you will see that she was able to survive cancer. And right now, she's still living and was able to get back to work as a nurse, even though she had cancer. Now, so why did I showed you, or why did I share this experience? No, so it is because it doesn't mean that when one person is diagnosed with cancer, life stops there. Previously, historically, when a person is diagnosed with cancer, they are telling us that the life is already numbered. But right now, because of the advances in the treatment, advances in nutrition therapy in particular, that is in my area, cancer is a treatable disease condition, and many people will survive from cancer. Okay? Next. Now, so when we take a look at the national statistics, no, like for example here in the Philippines, no, so I am from the Philippines, cancer is now the third leading cause of death nationwide in our country, with lung cancer ranking as the number one in mortality, or the one that is causing death among Filipinos. We have 184 cases diagnosed in 100,000 patients. And then 96 deaths related to cancer are reported. This is according to the World Health Organization. As to the global prevalence in 2022, there were an estimated 20 million new cancer cases in our area or in the Philippines. So the estimated number of people who were alive within 5 years following a cancer diagnosis in the world was 53.5 million. And about 1 in 5 people develop cancer in their lifetime, and approximately 1 in 9 men and 1 in 12 women die from cancer. Okay. Now, so this figure shows us the type of cancer that are encountered based on the gender. Now, so among males, it is found that the number one type of cancer that we are seeing among male is lung cancer, and then followed by colorectal cancer. The third is prostate cancer. The fourth is liver cancer. And the fifth is leukemia or blood dyscrasia. And among females, no, the number one cause or type of cancer is breast cancer, just like in the story earlier. The second one is colorectal cancer or the cancer of the colon and the rectum. And third is cervical cancer or cervix uteri. And the fourth is lung cancer. And the fifth is ovarian cancer or cancer of the ovary. Now, so when we say carcinogenesis, it is the origin or the development of cancer. Okay. Now, so I hope this video will generate an audio. Let's try. Do you hear the audio?
No, I think there's one setting in the Zoom where you can,
Okay.
I'm not sure. I also tried to search it for you actually just now, but I couldn't find whereby enable audio if I'm not mistaken.
Yes.
Tumor. A tumor is considered benign until it starts to invade nearby tissues, at which point it is then malignant.
Do you hear it now?
Yes, miss. We can hear the
Okay.
audio.
Okay, that's good. So we can
In healthy cells,
start it from the top.
proliferation is tightly regulated through a complex network of positive and the general feature of cancer is uncontrolled cell division, which leads to a mass of cells called a tumor. A tumor is considered benign until it starts to invade nearby tissues, at which point it is then malignant. In healthy cells, proliferation is tightly regulated through a complex network of positive and negative regulating factors. These factors make sure that cells divide only when they are supposed to. When genes encoding the positive regulators are mutated to produce overactive proteins, they are called oncogenes. Some viruses cause cancer through inserting their own copies of oncogenes into healthy cells. For example, the viral version of the SRC enzyme, a key molecule involved in cell signaling, is missing the regulatory domain that controls the human version. The lack of this domain triggers uncontrolled division in the host cells. As opposed to oncogenes, tumor suppressor genes encode proteins that negatively regulate proliferation. When they are mutated, cell division proceeds unchecked. Up to 50% of human tumors have mutations in the tumor suppressor gene coding for p53. This multifunctional protein is essential for cell cycle control and apoptosis. Uncontrolled cell proliferation leads to tumor growth. This means that the cells need more oxygen and nutrients. In a process called angiogenesis, they produce growth factors that promote blood vessels to form in the tumor. The more the tumor keeps growing, the more the cells keep dividing and changing, the higher the chance that cells can break free from the tumor and spread elsewhere in the body. The spread of cancer cells from the tumor is called metastasis and is responsible for nearly 90% of cancer-related deaths. A major challenge to the treatment of cancer is the fact that it is not just one disease. Each cancer patient has specific gene mutations, and every tumor is composed of a different group of mutated cells.
Okay, so this video just shows you something about how a normal cell becomes a tumor. So now we continue with our discussion about some terminologies. So for us to understand wait, I just need to have this into a slideshow. Okay, so there. So it mentioned carcinogenesis. It is the origin or development of cancer or formation of cancer cells. Genesis refers to formation. Carci is referring to cancer. So researchers believe that changes in gene function cause the normal cells to transform to cancerous cells. So there was also a mention about oncogenes. So we have to remember that oncogenes are altered genes that promote tumor growth and inhibit the process called apoptosis. So when we say apoptosis, when this process does not normally happen, so this is the reason why we are prone to having cancer cells. So oncogenes, these are the altered genes. They inhibit apoptosis or the so-called programmed cell death. So inhibition of this pathway, so the programmed cell death, because the cells that we have right now are not as the same cells that we were born. So the cells die off naturally and is replaced by new normal cells. So when apoptosis does not happen, so the oncogenes damages this process. So it inhibits the death of the weak cells. So this allows for the survival of the genetically damaged cancer cells. So that's why indirectly the oncogenes are the ones that causes the proliferation of cancer cells. So another is tumor suppressor genes. So the tumor suppressor genes are the exact opposite of oncogenes because these genes becomes deactivated in cancer cells. The loss of the tumor suppressor gene leads to unregulated cell growth. So when we have the loss of the tumor suppressor genes, that's the time that the cancer cells also proliferate. So examples are the APC or the adenomatosis polyposis coli and some breast cancer types or the breast cancer cells 1 and 2 and tumor suppressor that is a protein involved in preventing cancer. So remember that in cell reproduction, it is a process by which the cells duplicate their contents and then divide to yield multiple cells with similar if not duplicate contents. So when we say neoplasm, so it is the ability of the cell to proliferate. So when we say there is neoplasm, the type of cell that can undergo neoplasm are the labile and the stable cells. So what is the classification? We can have benign tumors that tend to grow slowly but may cause obstruction of adjacent tissue as a result of pressure. This is sometimes fatal when it is occurring in sites such as the brain. Then next is the malignant tumor, which are also called cancers, which usually grow most rapidly and tend to invade the surrounding tissues. These cells may be released and carried by the blood or lymph to distant sites where metastases or secondary tumors appear. So how do we classify a neoplasm? This may be based on the tissue which they arise. For example, your fibroma from the fibrous tissues, the chondroma from the cartilage, and the adenoma from the glandular tissue. We can also classify them according to histologic type, which is cystic or follicular. According to embryonic origin, we have carcinomas with malignant tissues from the ectoderm and the endoderm, and sarcomas from the mesoderm. So they can also be combined to be more specific in sources. That's why when you look at the chart of patients, you may see terminologies like adenocarcinoma, chondrosarcoma, liposarcoma, and also leukemia. Okay. Now, so sometimes when we see diagnosis of, for example, breast cancer, you will see the stage. No, so breast cancer stage 1, liver cancer stage 4. No, so this is graded. No, yung stages of cancer is graded as it provides a description of the cancer according to the size of the primary tumor and the involvement of the adjacent lymph nodes or the number of metastases. When we say that it is stage 1, this means that the tumor is small and has not grown outside the organ it started in. When we say it's stage 2, the tumor is larger than stage 1 but has not spread or to other nearby tissues. When it is stage 3, this means that the tumor is large and has spread to nearby tissues and lymph nodes. When it is stage 4, this means that the tumor has spread through the body or the lymphatic system to a distant site in the body. Now, so neoplasia is the uncontrolled progressive multiplication of cells constituting the fully developed disease. Now, so the process of carcinogenesis occurs in 2 stages. We have the initiation phase, which consists of the mutation of the cell, which then becomes neoplastic, and then the promotion stage where dormant cell may later be also deactivated to the exact though the exact mechanism is unknown. Now, so if you want to see the figure, now, so for example, these are the normal cells, no? And we have the initiation phase. No? So initiation where there is genetic mutation or change in the gene expression and will involve an abnormality in one cell. And then we have the promotion. Now, when it proceeds to the promotion stage, we have the proliferation or the increase in the number of the altered cells that results in the formation of the tumor, which may further develop, further tumor development to cause the formation of a tumor and is invading the whole cell system, and the cancerous tumor may be released into the bloodstream or the lymphatic system to proliferate also in other parts of the body. Okay. Now, so now let us proceed to nutrition. Now, when we say nutrition, it's about the science about the food and the drink that we have that can affect health. Now, so in terms of cancer, there are some food or parts of the food or nutrition-related factors that can affect carcinogens. Now, so we have promoters of carcinogenesis or the process of cancer production. Now, so first is aflatoxin. Now, so aflatoxin, based on researches and evidences, is produced by a contaminant mold that may grow in grains and peanuts in warm, humid environments, no? So, such as like our country and yours. No? So we have warm, humid environments. No? So grains and peanuts can be contaminated with mold that may produce aflatoxin, which is a promoter of cancer. Then we also have the polycyclic hydrocarbons, or the pyrosylates, produced in cooking methods that result in charred or brown protein food. So this will mean meats that has been grilled or barbecued. Then we have the nitrosamines, formed from amines present in some food that was added with nitrites and is added to fish and meat as preservative. So we also have the high-fat diets of the Western type of diet, wherein there is increase in animal fat and low-fiber diets associated with cancer. So when a person has a low-fiber diet and a high-fat diet, so that promotes the carcinogenesis process. The intake also of pickled vegetables and salted fish, and also intake of alcohol, particularly among the smokers or those who are smoking. Now, if you may ask, if ever, those are the ones that promotes cancer. Are there food that promotes or stops the promotion of carcinogen? Yes, of course, no? So we have the anti-promoters of carcinogen. So number one is vitamin C. No? So vitamin C food, vitamin C rich food inhibits the conversion of nitrates to nitrosamines. No? So nitrosamines. And then derivatives of vitamin A, coumarin, cabbage, family may alter the intestinal flora or the intestines, the endocrine or the immune system, the availability of substrates for neoplastic growth, or the rate of activation of carcinogen. So when you eat food that are rich in vitamin A, coumarin, and the cabbage family, this will help us decrease the rate of activation of carcinogen or the cancer-causing chemicals in food. So vitamin A, C, and E, and other minerals can prevent the oxidation of cells and formation of free radicals. So later on, we'll be discussing what particular minerals are involved with the anti-promotion of carcinogen. And then dietary fiber. No, dietary fiber which we get from our vegetables and fruit may be anti-carcinogenic by binding the fecal bile acids, and fruits and vegetables that are rich in phytochemicals can prevent cancer formation. Now we go to how does nutrition affect carcinogenesis. So how does nutrition or proper nutrition modify the carcinogenic process or the process by which we can get cancer? So nutrition can help or stop carcinogen metabolism, and it can also help cellular and host defense. It can affect cell differentiation, and it can also help decrease the tumor or help decrease tumor growth. So studies looking at the role of nutrition and diet as causal factors of cancers seek to identify the relationship between the diets of population groups and the categories of individuals and incidence of specific cancers. Some dietary carcinogens, do you know that some dietary carcinogens are naturally occurring pesticides or herbicides produced by plants to protect them from fungi, insects, and animals? And some secondary metabolites are produced by molds and aflatoxin, as what has been mentioned earlier. So there are also dietary enhancers of carcinogenesis, like for example, the way we prepare our food and preserve the food that we are eating. So food preparation and preservation methods may also contribute to dietary carcinogen ingestion, such as the formation of the PA. I have already mentioned this, or the polycyclic aromatic hydrocarbons. So when does this pass or polycyclic aromatic hydrocarbons form? They form on the surface of red meats or the saturated fat in red meats whenever we grill them at high temperatures. That's why in grilling, it is inevitable that we have the charred part in the meat. So that part is carcinogenic or is cancer causing. Okay. So these are the dietary inhibitors of carcinogenesis. So we have the antioxidants, your vitamin C, carotenoids, vitamin E, selenium, and zinc. So we also have the phytochemicals or the bioactive compounds. We call this the biologically active compounds of plants. Your phytosterols, the lycopene, the anthocyanins, the lutein, and the sulforaphanes. So we'll be discussing each of this later in a while. So these are examples of vegetables that are cruciferous, no? These vegetables are very good cancer fighters. So you have your broccoli, your cabbage, cauliflower, the arugula, you have the turnip, the kale, the bok choy, or the Chinese cabbage, and the Brussels sprouts. No? So these are just some examples of certain food or vegetables that are very good inhibitors of carcinogenesis. In the next few slides, we'll be discussing about the bioactive compounds. No? So these are the components of food in plants or chemicals found in plants that are evidence, no, or has been studied to fight off carcinogen. Now, so when we say bioactive compounds, these are chemicals found in small amounts in plants and in certain food. No, so they are extra nutritional constituents that typically occur in small quantities in food and promote good health. So one example, so this is a reference for this one, is our lycopene, resveratrol, the lignin, the tannins, and the indoles. Now, we also have the so-called polyphenolic compounds. No? So the polyphenolic compounds in plants are diverse group of natural compounds with multiple phenolic functions. No? So the occurrence is in plants. What are the roles of the polyphenolic compounds as what has been found in researches and studies before and right now? No? So the role is protection against heart disease, and then metabolic dysfunction, and slowing down of aging or healthy aging, for example. But right now, one example of advantage is the anti-carcinogenic property of these polyphenolic compounds. Now, so the third role is very important for our topic for today because it has the polyphenolic compounds, no, has anti-carcinogenic properties. No, it fights off cancer. So you might be wondering, what are these food items that are very rich in polyphenolic compounds? Okay, so just stick around and listen to my lecture. No, so the polyphenolic compounds come in the form of polymers, esters, and glycosides. Now, so if you're wondering about how does the polyphenolic compounds act in our body? No, so what is the pathway? So when you eat food that are rich in polyphenols, they enter the body, no? And then in our intestines, no, they are hydrolyzed or they are acted upon by the microbes, no, our gut. No, the good bacteria in our gut hydrolyzes the polyphenols, and then eventually it is absorbed by the body. And when this is absorbed by the body, this is the time that it will attack upon, no, it will fight off the tumors, the tumor cells, the cancer cells, no. So that is the way by which they can act upon in our body. We also have the group or the family of flavonoids. No? So we have the anthocyanins, the campherols, quercetin, and the lutein. So these are the active biocompounds. No? So now, this is the answer to the question, what food are rich, no, in bioactive compounds that can fight off cancer? So for the flavonoids, examples of food are the chocolates, the red wine, the tea, the apple, the onions, the broccoli, and the olives. Now, so in particular, the bioactive compounds are the flavonols, we call it flavonols, isoflavones, and anthocyanidins. For the phenolic compounds or the phenolic acids, we have coffee, black tea, cereals. So the active biocompound is benzoic acid and cinnamic acid. So we also have the steel beans from the grapes, the peanuts, the red wine, and the active compound is resveratrol. Now, so when you let the grapes, no, the red grapes undergo fermentation, that's the time when resveratrol is developed. No? And then the lignans, our flaxseed oil, the clover, and the lucerne, it is rich in secoisolaricerenol and meta-irisenol, no, the active biocompounds. No? So, how does the action, now what is the action or direct inhibitory actions of these bioactive compounds? Now, so first, it can lead to the reduction of the damage to the DNA. Now, so several chemopreventive actions elicit their anti-cancer effects by modulating the enzymatic systems responsible for neutralizing the carcinogens. Now, so one example is the isothiocyanates found in cruciferous vegetable. Now, so the isothiocyanates, no, so affect the enzymatic system, no, and it neutralizes the carcinogen. So these are the examples of the cruciferous vegetables that I have said earlier. No? So we need to eat more of these vegetables. Yeah. And the next is the bioactive compounds can also give cytotoxicity. It is toxic against tumor cells. Like for example, the phenyl isothionates from cruciferous vegetables, the curcumin from the turmeric, and the resveratrol from the grapes. They also have anti-angiogenic properties. No? So the polyphenol found in green tea inhibits vascular endothelial growth factor receptor 2, a key receptor involved in tumor angiogenesis. So what are examples? We have the ellagic acid, a phenolic acid found in some fruits, like for example, your raspberries and strawberries, and the anthocyanidin in blueberries. Now, so are you eating blueberries, raspberries, and strawberries? So you're eating also anti-angiogenic properties. We also have anti-inflammatory effects. No? So relationships between inflammation and cancer is suggested by identification of a number of inflammatory conditions that predispose patients to cancer. So the next question is, Ma'am Jen, how much do we need? How much broccoli? How much cauliflower? No, so now this is the answer. So food with chemopreventive effects in a daily diet. No, so for Brussels sprouts, you need to be eating around 1/2 cup of Brussels sprouts. For broccoli, cauliflower, and cabbage, it is about 1/2 cup of these vegetables. Garlic, 2 cloves of garlic. Onions or shallots, 1/2 cup. Spinach, the watercress, 1/2 cup. Tomato paste, 1 tablespoon, because from tomato paste you will get lycopene. Turmeric is 1 teaspoon. Raspberries, blueberries is 1/2 cup. Grapes is 1/2 cup. Dark chocolate, it should be 70% cocoa or cacao, 40 grams. Citrus fruit juice is 1/2 cup. Green tea should be taken 3 times daily of 250 ml per glass, or 250 ml green tea 3 times a day, and red wine is about 1 glass. No, so the problem only with red wine is that there is alcohol. No, so we do not want to really promote too much red wine because of the alcohol content. But if you can get other fermented red wine or fermented grapes without the alcohol component, that is the best one. Yeah. Now, so these are the different interacting mechanisms. No? So for bioactive compounds, it has direct effects on the immune responsiveness and inflammation. It has indirect effects of overnutrition and obesity, the risk factors for colorectal cancer, and direct effect for gut microbiota. Now, so what is the mechanism? So for example, specific minerals, like for example, calcium. Now, so the mineral calcium, we know that essential for bone and dental health. The ability of ionized calcium to form insoluble soaps with tumor, promoting free fatty acid and bile acids in the colonic lumen, lead to the hypothesis that calcium is anti-cancer or anti-neoplastic. So calcium. And then additional mechanisms include the inhibition of cell proliferation, promotion of cell differentiation. So what is the moral of the story here? We need to be having adequate calcium in our diet. So that we can have the ionized calcium that can be anti-neoplastic. And then, what are the evidences for the claims on calcium? In cohort studies, calcium beyond ayan, 700 to 1,000 milligrams per day. I just cannot read it. Let's share again. Okay, so it has been found in studies that calcium, in cohort studies, that calcium beyond 700 to 1,000 milligrams per day has been found to have minimal incremental effect on lowering colorectal cancer risk, and supplemental calcium did not further benefit participants with higher dietary calcium intake. So the lesson here is that we should be getting our calcium from the natural sources or from the food. So the association between calcium intake and colorectal neoplasm may differ by anatomic location, with stronger association observed for cancers in the distal colon and the rectum. So the effects of calcium will be beneficial for types of cancer in the area of the colon and the rectum. The inverse association between calcium and colorectal neoplasm may be confined to individuals with high vitamin D level. So another is the study by Burkitt. Ayan, high fiber intake. Wait, I'll just share it again. I can see it in my end. So another study by Burkitt in 1970s was hypothesized that a high fiber intake or intake of fiber from fruits and vegetables protected against colorectal cancer, and observations on the low CRC incidence among Africans who consume a high fiber diet. So what is the proposed mechanism for this one? The proposed mechanism is to reduce concentration of intestinal carcinogen due to increased stool mass and decreased transit time. So when you have a higher fiber intake, we have more stool mass, and we tend to move our bowel more. So you have less exposure of the carcinogen in the colon because you move it right away due to the fiber intake. So high fiber diets can increase the tendency to have cancer, which can be metabolized by the gut bacteria and can cause cancer promotion. So a high fat intake, specifically animal saturated fat, and also monounsaturated fat but not vegetable fat like linoleic acid or cholesterol, increase colon cancer risk. So there are some placebo-controlled, randomized controlled trial that shows that omega-3 polyunsaturated fatty acid administration of 2 grams daily for 6 months decrease the polyp number, size, and overall burden in patients with familial adenomatous polyposis. Omega-6 PUFAs or omega-6 polyunsaturated fatty acid have pro-inflammatory effects, and these are attributed to the antagonism of omega-3 polyunsaturated fatty acid. Yan. So red meats can also increase the risk to having cancer. No? So persons who are consuming at least 100 grams per day of red meat have approximately higher risk of colorectal cancer, and an intake of 50 grams per day increase in processed meats can also increase the risk for cancer. The risk increases linearly with increasing the intake of red and processed meats up to approximately 140 grams per day. Beyond this level, the risk is less pronounced. Now, so in case of unprocessed meat, inorganic sulfur is used as a preservative. Now, so the heme iron in red meat can induce oxidative stress, colonocyte proliferation, and the endogenous formation of NOCs. Now, so NOCs are the N-nitroso compounds, which are very potent carcinogen. Now, so high consumption of heme iron, but not other forms of iron, have also been associated with increased risk for colorectal cancers or tumors. Now, so constituents in milk other than calcium may also contribute to the anti-neoplastic activity, including conjugated linoleic acid that has antioxidant, anti-inflammatory, and immune modulatory properties. Let's transfer his down. Dairy products in particular may also protect against colorectal neoplasia because of the high content of calcium and other micronutrients and bioactive constituents. Now, so that will mean it is also good to consume dairy products mainly because they are also good sources of calcium. Antioxidants, or the ROS, or the reactive oxygen species scavengers, protect the cells from oxidative stress that can initiate and promote carcinogenesis by inducing gene mutation, DNA damage, genome instability, cell proliferation, and inflammation. Carotenoids, for example, your beta-carotene is a vitamin A precursor, and also your lycopene. Now, so together with vitamin C, vitamin E have potent and antioxidative, anti-inflammatory properties. That's why we need to be eating the yellow or the orange fruits and vegetables because they are the ones that are rich in beta-carotene. Selenium has no such action itself, but it is required for the antioxidative activity of selenoenzymes. Now, selenium does not have a direct effect on anti-cancer properties, but it is needed by the selenoenzymes to induce its antioxidative activity. Next condition that may be and has been shown right now to affect cancer is increased energy intake. Now, so the overweight, obese individuals has been shown or has been identified as a risk factor for some cancer, or this condition, obesity in itself, as a risk factor for some cancer. There's a role of increasing the levels of IGF, or the insulin-like growth factor in obesity, is related to the higher risk to having cancer. So the study by Willett et al. In 1999, the health professional study and the nurses health follow-up study have shown that as an individual has increased their BMI, or the body mass index, certain disease conditions have arise. So we have diabetes, hypertension, cholelithiasis, and coronary heart disease. But when they did a further study, they have also seen other conditions such as obstructive sleep apnea, asthma, and most specifically, cancer. Okay, so this is their study. So at this point, I am already done with clinical nutrition for cancer prevention. And the takeaway message is that we need to be eating our sources of bioactive compounds. We need to be eating plant-based proteins and plant-based fruits and vegetables, no? So that we'll be able to get the antioxidant properties that is needed to fight off cancer. So now I am moving to another topic, which is cancer management. Now, so how do we use nutrition as a way to manage problems related to cancer? Okay, so what are the consequences of treatment of cancer on nutrition? So we have general systemic effect, local effect on organs, effect of cancer therapy on nutritional status. So when we say general systemic effect, some metabolic alterations are seen commonly in patients with neoplastic disease. So one of them is the so-called cachexia. So cancer cachexia is characterized by anorexia or lack of appetite, tissue wasting or loss of weight or wasting, weakness, impaired organ function, apathy, water and electrolyte imbalance, and decreased resistance to infection. Decreased food intake occurs even when there are no mechanical barriers involved, primarily as a result of anorexia. So the cancer in itself may cause loss of appetite, altered metabolism and competition for nutrients, and a neoplasm, once it reaches a certain size, it continues to grow regardless of the nutritional needs of the host. So there is nutritional deprivation that harms the host more than it harms the tumor. Like for example, if a person with cancer eats healthy food, for example, the antioxidants, eats fruits, the neoplastic cells are also competing with nutrients. That's why they are more aggressive than the normal cells. No, so that is the reason why a person with cancer will usually lose weight and may also experience cancer cachexia. So this figure shows us the signs and symptoms of cancer cachexia. So weight loss, sarcopenia, or the loss of lean body mass, and it is substituted or replaced with fat, early satiety, taste and smell, and or smell changes, loss of appetite, depression and anxiety, nausea and vomiting, pain, fatigue, and anorexia. So we need to know how. How are we going to manage this condition? So cancer can also have local effect on organs. Gastric carcinomas can cause blood loss and other protein-rich fluid. Nausea and vomiting can develop as a result of obstruction in the GI tract, can lead to fluid, electrolyte and protein loss. Intestinal damage can result in malabsorption. Cancer of the liver may cause decrease in albumin production because the liver produces albumin and consequent hypoalbuminemia or low blood levels of albumin. Carcinoma of the liver causes prothrombin deficiency or the patient may be prone to having bleeding. So what are the effects of therapy? Dr. City has already discussed this one. So I will not be dealing so much on this except for the effects on nutrition. No? So the surgery may potentially alter organ function and contribute to reduction in food intake and weight loss. Now, so radiation can cause anorexia, nausea, and vomiting. Changes in sense of taste and sense of smell, and radiation of the thorax, the esophagus, can cause esophagitis, dysphagia, or difficulty in swallowing, which will mean there should be an alteration in the consistency of the diet. If the patient is given a regular diet, that patient cannot eat the regular diet. Maybe we can give a soft diet or a blenderized type of meal. Chemotherapy can cause severe pain during food intake, like for example, the effects on ulceration, glossitis, stomatitis, and mucositis, nausea and vomiting and diarrhea, anorexia, and also immunotherapy, the newer type of therapy for cancer, can cause nausea, anorexia, diarrhea, and dysgeusia. So what is the medical nutrition therapy? So cancer patients, we know that are high risk of malnutrition. So nutritional care should be individualized. And since needs vary from one patient to another, it is important for us as health professionals to be able to determine the progress of the disease and the treatment use. So what is the value of medical nutrition therapy or clinical nutrition? It improves treatment tolerance, reduces the need for breaks in treatments, decreases the intentional weight and lean loss of body mass, and improves the quality of life. Now, so in this way, if you have medical nutrition therapy or is practicing the correct clinical nutrition for cancer patients, now we will be reducing need for breaks. That will mean the patient can go on directly and finish all of the therapy. Now, so if you are able to give nutrition support for these patients. Now, so medical nutrition therapy or clinical nutrition prevents unplanned hospitalization by greater than 50%. Imagine the cost that will be saved, reduce length of hospital stays, and most especially improve survival for patients who are undergoing cancer treatments. So these are the goal of nutritional management: improve or maintain the patient's optimal nutritional status, maintain the patient's strength during therapy, prevent and reverse immunosuppression, and provide long or short-term measures to ensure survival. So these are the short-term goals. Now, provide optimal nutrition support by treating symptom per symptom management, achieve or maintain desirable body weight, correct vitamin and mineral abnormalities, and correct fluid and electrolyte imbalance. So each patient will have their individual energy needs. Not all cancer patients will lose weight. Some patients, they become overweight or obese. No? So we have to be careful. We have to be able to give just the adequate amounts of energy for our patients. So some may gain weight, so energy adjustment should be made. So here, this shows us the recommended targeted energy requirements for different types of cancer. So for example, a cancer patient who is under hypermetabolic or stress condition can be given 35 kilocalories per kilogram per day of energy and a protein need range of between 1.5 to 2.5 grams per kilogram per day. Or a cancer patient who is on nutritional repletion and weight gain can be given a range of 30 to 35 kilocalories per kilogram per day, or a protein requirement of 1 to 1.5 grams per kilogram per day. So as to how this will be computed and will be translated to actual food, if you are not a dietitian, doctors, the nurses will need to refer their patient to a nutritionist dietitian so that all of these computations will be realized and be translated into an actual diet and will be given to a patient which the patient can consume. So what are some strategies for weight loss among cancer patients? So we can give a high calorie diet, so up to about 2,000. This will be individualized if the patient is really needing an upbuilding diet, about 3,000 to 4,000 kilocalories per day. But take note, this is individualized. This is not all the time practice. So sometimes some patients, they gain weight. Why are you going to give 3,000 kilocalories per day? So protein for maintenance may be about 90 to 100 grams per day, or repletion may require 100 to 200 grams per day. Take note, this is individualized depending on the case of the patient. So oral feeding is recommended Very important. If the GI tract is functional, oral intake is tolerated, no? So we give enteral and oral nutrition. Otherwise, nutrition support is necessary to correct poor nutritional status. So now we go to the strategies. No? So how do we manage each specific condition? So anorexia, no? You will see in the doctor's order, they will write there small frequent feedings or SFF of food with high nutrient density and individualized for patients' needs and preferences. So for example, the problem is the patient has no appetite. So what are some simple tips or strategies? No, we can counsel the patient to eat more small, frequent meals and healthy snacks throughout the day. We offer the patient high protein food first in the meal while the appetite is strongest. So there are times that the appetite is strongest, sometimes in the morning, sometimes in the evening. So food such as beans, chicken, fish, meat, yogurt, and eggs. We can also offer milkshakes, smoothies, juice, and soup, most especially if the patient is not able to chew properly. When there is swallowing difficulty, they can have the nutrient dense food through straw. Sip only small amounts of liquids during meals and take the liquids in between meals so that we can maximize the intake of oral food. Seek food that appeal to the sense of the smell. Perform frequent mouth care and consider oral nutrition supplements in the form of commercial enteral formulas not to add on energy and protein. So this shows us healthy food that can be added in the diet. For example, you can add avocado mayonnaise or salad dressing to the sandwiches or the bread. We can have spreads, healthy spreads. Like for example, you can have peanut butter, olive dressing, your avocado, which is a very good source of monounsaturated fatty acid, nuts and seeds, whole grains. Eat bread that are with whole grains, like for example, your wheat bread and high fiber cereals. If the patient is experiencing metallic taste, so we can try using plastic cutlery and glass cooking pots in our cookery. Add tart flavors from lemon or other citrus fruit, vinegar, and pickled food, except if the patient has sore mouth. We can also use sweeteners like maple syrup or agave nectar, to counter off the metallic taste. So if the taste of the patient is more on suffering from sweet taste, it's too much sweet in the tongue. So dilute fruit juice and other sweet drinks with water or ice. Try vegetables instead of fruit. Use a little salt or lemon juice to food. Sip and then hold herbal tea for a moment in the mouth before a patient will eat. If there is bitter taste in the tongue, we add a little honey or sugar to the food. Better to give honey because honey is having more additional B-complex vitamins and other antioxidants also because they are from flowers that was sipped by the bee to form a nectar. Add sweet fruit to meals and the patient can drink ginger ale or mint tea. When the problem is the patient being too tired to fix the meals. So this happens during chemotherapy. So we tell also the patient to eat small amounts of food throughout the day, even if they are not hungry. They can consume meals when they have the most energy. They can already choose convenient food, frozen foods like frozen meals, canned food, or takeout until they have more energy. Try a healthy drink like fruit smoothies or milk and milk alternative shakes if they don't feel well enough to prepare or eat a meal. When they have the energy, they can cook in batches, freeze in portions that can be easily reheated, or the so-called idea meal preps. And they can also ask a friend or a family member to assist them in buying and preparing meals. When the patient is nauseated or often vomits, They can have light meal or snack before the treatment. Now, so if nausea occurs during treatment, try not eating for 1 to 2 hours beforehand, then wait for a few hours after treatment or before eating again. So we can serve bland, soft, easy to digest food rather than heavy meals. We can offer dry food like crackers, breadsticks, or toast throughout the day to counteract vomiting and nauseating. We avoid food that are very sweet, greasy, fried, or spicy, or those that have strong smell. We tell the patient to sit up or recline with the head raised 1 hour after eating. They can also suck on hard candies such as those with peppermints or lemon drops if the mouth tastes bad. Sip water and other liquids like ginger ale, sports drinks, broth, or herbal teas. Wear clothes that are loose and comfortable. Sometimes if the patient is wearing too much clothing or too much tight clothes, this can aggravate nausea and vomiting. After eating, relax or sitting up with or your head and shoulder raised if you need to lie down. When there is chewing and swallowing problems, we choose foods that are easy to swallow. So we give more of the liquid type of food like the milkshakes, scrambled eggs, and cooked cereal. Cook food until they are soft and tender, cut into small pieces, and we can use a blender or a food processor. We can also thicken liquids to make it easier to swallow. We can add gelatin, pureed vegetables or fruit, instant potatoes, cornstarch, infant rice, cereal, or commercial thickeners for those who have chewing and swallowing problems. We need to moisten and soften food with gravy, sauces, broth, and yogurt. They can have sip drinks through a straw to make them easier to swallow. We do not offer hot food and drinks, spicy food and juices high in acid, sharp or crunchy food, and alcoholic drinks. And we tell the patient to sit upright and bend the head slightly forward when eating or drinking, or stay upright up to about 30 minutes after eating. When there is dry mouth, we have very sweet or tart food drinks such as lemonade to help make the patient more saliva. And then chew gum or suck on hard candy, ice pops, or ice chips. Eat food that are easy to swallow, moisten the food with sauce, gravy, or salad. We can prepare healthy smoothies from low-acid fruits like melon, bananas, peaches, and add milk, yogurt, and silken tofu to add more protein. Rinse the mouth every 1 to 2 hours. Do not use mouthwash that contains alcohol. Avoid food that can hurt the mouth like spicy, sour, salty, hard, or crunchy food. In the Philippines, we have the so-called chicharon, which is very crunchy, so we don't give that to those with dry mouth. Do not drink any type of alcohol, beer, or wine. When there is diarrhea, we drink plenty of non-carbonated, caffeine-free fluids such as water, sports drinks, and clear broth. We give low-fiber diet, avoid nuts, raw fruits, vegetables, whole grains, and high-soluble fiber. Now we can give banana, melon, canned peaches, and oatmeal. Limit grease, fried, spicy. So when a patient is having diarrhea, we give a low-fat diet. Now, avoid food high in fiber, high sugar, very hot or cold drinks, carbonated drinks, cruciferous vegetables, and hard to digest food. Avoid sugar, alcohol-containing food items, those with xylitol, sorbitol, and mannitol, because this can aggravate diarrhea. Eat food and liquids that are high in sodium and potassium, because as the patient moves more bowel, more sodium and potassium goes out as well. So we need to give oral rehydration solution or ORS. For constipation, we gradually add more fiber in the diet. We let the patient drink plenty of liquids throughout the day. We try water, fruit, and or vegetable juices, hot and warm liquids like cocoa, tea, and lemon water can also help. Now you can prepare lemon water. So you have water, slice some lemon, and you put it in the water, and you chill it in the refrigerator. That can be a good way by which we'll be able to manage constipation. Drink hot liquids to help relieve constipation. Now, if you do not have the urge to move your bowel, and then you would want to have a test, like for example, fecalysis, and you cannot move, so you cannot submit your bowel. So you can drink coffee, and right after you feel the urge. Choose food that are natural laxatives like prunes, rhubarb, and ripe papaya. Try eating 1/4 cup of prunes or drinking 1/2 cup of prune juice. Being physically more active when you can, and limit certain foods if you develop gas, like broccoli, cabbage, cauliflower, beans, and cucumbers, because these vegetables are gas formers. No? So, yeah, and gradually, that was just repeated. In bloating, we eliminate food that are greasy, fried, and fatty food. So low-fat diet and gas-producing food. And we can ask the patient to drink through a straw to lessen the engulf air. For early satiety, small frequent feeds, high calorie density feedings, limit liquid meals, avoid gas formers, avoid high fat or greasy food, and exercise between meals. For cancer patients who are of very low immune system, we give them the neutropenic diet. No, so we cook all the food thoroughly. We avoid raw eggs, fish, meat, and poultry because they are immunocompromised. Avoid spoiled, moldy, or damaged food like cheeses, fruits and vegetables that we usually buy that are already cut up, because we are not sure if the knife that was used to cut up those vegetables are clean or sterile. So we tell the patients to make sure that they are the one cutting up the whole fruits. No? So yeah. Avoid unpasteurized beverages and wash hands frequently. For fatigue, we have already discussed this one, so I'll skip this one. And this is the last slide. The American Institute of Cancer Research recommendations for cancer prevention. To prevent cancer, people should aim to follow as many of the 10 cancer prevention recommendations. Eat a diet rich in whole grains, vegetables, fruit, and beans. Limit consumption of fast food. For mothers, breastfeed the baby if they can. Be in a healthy weight, be physically active, limit consumption of red meats and processed meats, limit consumption of sugar-sweetened beverages or the high fructose corn syrup, limit alcohol consumption, and do not use supplements for cancer prevention. So most of the antioxidants that we need can be taken from the diet. Now, so following this recommendation is likely to reduce also the intake of salt, saturated, and trans fats, which together will help prevent other non-communicable diseases. So with that, these are my references. Thank you very much.
Thank you so much, Dr. Jane, for the enlightening session. It is incredible to see how nutrition can play such a pivotal role in both prevention and recovery. And we can see that clinical nutrition play a crucial role in both cancer prevention and management. And overall, the clinical nutrition improves treatment outcome, quality of life, and recovery to cancer patients. So we have participant will be asked about this topic. I would say Alfaida Rizky. You can ask Dr. Jane directly.
Yes, go ahead, Alfaida. You have a question?
Okay, we can help you to unmute first.
I think she has written her question. I can read it. Yes, you're audible, yes.
Okay, as what I'm typing, that as you mentioned before, that fiber is important as an anti-carcinogenic, but how about the fiber drink that exists in society? Because we know that those fiber drinks contain much sugars and also can cause diabetes. And is it still can work as anti-carcinogenic, or it's only work on fiber from fruit? Thank you.
The fiber that I am talking about in juices should come from the natural fiber of fruits. For example, you're going to make a smoothie out of ripe papaya, banana, the natural fruits. Then you blend it. And then, specifically, it should be the one that you are the one preparing it so that you can control the amount of sugar that you're going to put. Ideally, the sugar should come from the natural sugar of the fruit. We know that fruits are naturally tasting as sweet. So if we would want to add some more sweetness, we just add around 1 to 2 teaspoons of honey. But the commercially prepared juices, for example, are some of them are only artificially flavored. So we do not get the so-called bioactive compounds because they are just flavorings. I hope I have answered the question.
Yes, thank you for the explanation. One more question in the chat box. How can healthcare profession ensure effective communication with the cancer patients regarding the importance of nutrition in their treatment plan?
Okay, so that is a very good question. Thank you, Fadila Anna. Risky Anna. We need to know how to do counseling to our patients. And we need to know what state the patient is in. Sometimes, as healthcare professionals, based on my experience, we are so very eager and we are so very excited to share the information. But we need to assess the patient individually. We need to know at what point that patient is in. Sometimes the patient is in the is in the state where that patient is not ready to receive the counseling. When the patient is newly diagnosed, so sometimes the patient is not ready to receive our counseling. So what we do is we adjust. Now, so what we are doing right now, we're educating ourselves. Now, we are going to be healthcare professionals. We are empowered what to do, what to give, what instruction, when the patient cannot eat because the patient has chewing, swallowing problems. But we need to determine if that patient is ready. So what if the patient is not ready? No, so what we do is we just say hello, how are you? Okay, so when you are just feeling good, I will come back. And then you come back again. And then if that patient is in a state of acceptance already, no, then that will be the perfect timing for you to give and ensure effective communication with the patient. Now, so of course, effective communication will mean talking with the patient. So there should be no barrier. Now, so as what Dr. City have said, that we healthcare professionals should be helpful and should also be a good person. Now, so that the patient will trust us. Now, so being able to go to the patient with a smile. No, so even if you don't feel well, you just smile. How are you? I am Jen from the dietary department. I'm your nutritionist. How are you? You just ask them, I'm not feeling well because I just knew that I had cancer, and the patient will cry. So you will just be empathetic to the patient. That's my answer.
Yeah, thank you, Sis Jane, for the explanation. But I'm sorry, our time is up. Thank you so much for participating as speaker in our Zoom meeting. If you don't mind, we ask for your presentation through the email. Dr. Jane, it's okay?
Yes.
Yeah.
You would want a copy of my presentation?
Yeah, we need to deliver to our
Yes.
student. Yeah.
Yes. Okay. I will give you a
Yeah.
handout on my presentation.
Yes, thank you so much. Because
I will send.
Yeah, you can send it through the email with the Dr. Fihir.
Yes, I can send it to Dr. Fihir.
Yes, thank you so much. We, in the end of the session, we certainly hope to have the opportunity to meet you in person in Lombok with Dr. Siti. Once again, thank you
Sure.
so much. Yeah, I hope so in the next meeting, we hope we can share to the experience for the time with you. Before
My
we end the
pleasure.
session, yeah, I hope so soon, as much as possible. Okay, before we end of the session, we want to take a picture with you, Dr. Chen. Maybe any possible to take a picture with Dr. Siti? Hello, Dr. Siti. Because Dr. Siti is
Yes, yes, yes. I'm
stay
still here.
available. Yes.
Yeah,
Yeah.
hold on, eh. I got back to my office room because I have my own mini
Yes.
office here.
We have another speaker from Poltekkes Mataram, Miss Mira and Miss Putu. You can join us to take a picture together. Yeah. Okay, thank Miss Mira and Miss Putu is come from nurse in Polytechnic. You can say hello, Miss. They will explain about nurse related to our topic today. Okay, we can take a picture together. I will count for all of us. Okay, 1, 2, 3. Once more time. 1, 2, 3. Okay, that's all. Thank you so much for all of the speaker. We're really glad you have a time for us, and we hope we can meet in the future. That is our first session seminar for today. We extend our deepest gratitude to our speaker for their insightful presentation and valuable contribution. Can we give applause to all our participants and our speaker for today?
Thank you.
Thank you so much, Dr. Siti and Dr. Jenny. Goodbye.
Bye. Thank
Thank
you.
you.
Okay, thank you so much for all participants still in our Zoom meeting. And this is the end of our first session, and back to MC to continue our next session.
Thank you to all speakers for our topic and Mr. Arik Kusuma for the highly engaging sessions this far. Now, let us proceed to the next sessions and guide by Ms. Nursanya Fahmi Mantika. Ms. Sanya Nur Fahmi Mantika, or we call it Sania, is a final year student in medical laboratory technology with outstanding track record in both academic and extracurricular achievements. So we warmly invite the two awesome speakers and Ms. Nursanya Fahmi Mantika to take the stage and lead the sessions.
Okay, good afternoon, everyone. I know that all of us are a little bit tired since earlier today, but I would like to express my sincere gratitude to all participants for staying with us in this webinar until now and until very the end. Well, my name is Nur Sania Fahmimantika, and I feel honored to serve as moderator for these important sessions. Well, as we know that cancer continues to be a significant global health challenge, and our few past experts already delivered an awesome insight about cancer, and now we still have two more experts who will discuss and focus on two vital aspects. The first aspect is educations and early detections on cancer in the community, and the second one is improving the competency of nursing graduates in cancer treatment. Well, our goal in the sessions is to share insight and strategies that can be applied to preventions, early detections, and professional care in the fight against the cancer itself. But before we begin, let me share a few housekeeping reminders. Each speaker will have present about 20 minutes and followed by a Q&A session at the end of the sessions. All the participants are kindly requested to mute their microphones during the speaker's presentations. And if you have a question, please write them in the chat box by mentioning your name, the speaker's name if applicable, and also the question itself. Well, ladies and gentlemen, we are privileged to have with us our two outstanding professionals who are deeply involved in this cancer education and care. We have Mrs. Mira Utaminingsih, MNSC, who will speak about educations and early detections of cancer in the community. And we also have Mrs. Putu Sumartini, Eskep Nurse MCUP, who will share insight on improving the competency of nursing graduates in cancer treatment. Well, both our speaker is a lecturer of nursing department in Health Poltekkes Mataram. Without further delay, let's begin with Mrs. Mira Utaminingsih, MNSC. Assalamualaikum, Mrs. How are you? Are you with us? Oh, okay. Wait, I'm going to tell the ID. Okay. Okay, Miss Mira, are you can unmuting yourself?
Yes.
Okay.
Thank you. Can you hear
Well,
me
because
clearly?
Miss Mira is already ready, well, without further ado, let's invite Miss Mira Utaminingsih for explain to us about educations and early detections of cancer in the community. To Miss Mira, the floor is yours.
Okay, thank you, Sania. First of all, I would like to ask, can I share the screen from here or from the moderator?
You can share your screen by yourself.
Okay. All right, then, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, colleagues and participants. I hope you still keep it up with this international webinar. It is an honor and a privilege for me to be in this distinguished gathering of experts. And as mentioned by Sania, my name is Mira Utaminingsih. I am a nurse and a master in nursing science. I am a lecturer and a researcher in the Mataram Health Polytechnic under the Ministry of Health of the Republic of Indonesia. And first of all, I would like to begin by thanking the committee for inviting me to speak at this important event. And today I will be discussing about education and early detections of cancer in the community. Let me first share my screen. All right. Has everyone seen my screen?
Yes, miss, it's clearing.
Okay, good. Okay, so I will talk about education and early detection of cancer in the communities. And here are the objectives of my speech today. First is the burden of cancer. We will discuss about the burden of cancer for the community health. And second is the cancer prevention. We will discuss about how can we prevent the cancer case. And the third is cancer early detection. We will discuss about how can we detect cancer in the early stage. And the last is education initiative for community. We will talk and we will discuss about what can we do to help the community to lower the case of cancer. Okay, let's start with the first point, the burden of cancer. The burden of cancer for the community health. If we talk about the burden of the cancer in the community, we will talk about the incidence of the cancer worldwide. The global incidence of cancer recently showed that in 2022, almost 20 million cases of cancer were diagnosed, and around 10 million of them was result in mortality, and it means that 50% of them result in mortality and making it the leading killer. And the lung cancer is the most common that cause mortality in cancer. And for a person who sadly diagnosed cancer, it can be easily become an end of life situation. If we see the future, by 2040, the number of new cancer cases is estimated to increase to 28.5 million globally, and the global cancer burden will still growing due to the population growth, due to the growth of aging populations, and as well as changes in exposure to risk factors such as tobacco, pollution, and also other carcinogenic chemical exposure that can be found around us. And we see the cancer rates is vary by country and within countries. For example, cervical cancer is most common in countries with lower life expectancy, with lower education and lower standard of living. And if we see from the point of view of the patient, the personal burden of patient include painful experience, tiredness, anxiety, a depressed mood, and financial burden. In fact, late-stage cancer treatments have a significant financial and social impact, and cancer-related financial burden was associated with lower health-related quality of life. It increased risk of depression and a higher frequency of worrying about cancer recurrence and death. Okay, so now we go back to the community health. The community health is the ultimate goal of all health programs worldwide, and it refers to the overall well-being and health of a community, including its individuals, families, and institutions, and it involves various activities and initiatives aimed at promoting healthy lifestyles, preventing diseases, and improving access to healthcare for all members of the community. And now we know that cancer plays a big burden to the community and decrease the level of community health. So what can we do? Well, so far, we have learned from the previous speakers how to diagnose cancer, the stages of cancer, the care for cancer patients, the diets for cancer patients. Now, we will hold back to time when the cancer has not detected yet. I'm sure that we really don't want to face this case. And if we could turn back time, I am sure that we will make any efforts to prevent it from happening. But unfortunately, we cannot. But we still be able to prevent cancer for a better future of community health. So what we need to do is to do the prevention. Now we're going on to the second topic about cancer preventions. The question is, can we really prevent cancer? If we look at previous studies, many people, including scientists, they used to think that cancer was a matter of bad luck and there wasn't much you could do to avoid getting cancer. However, now let's look at what the recent research talk about cancer prevention. 70% of total cancer cases have modifiable and preventable risk factors. In other words, 70% of total cancer cases could have been averted through preventable screening and healthy lifestyle choices, according to reports published in National Center for Biotechnology Information. And experts now believe that up to 40% cancer cases are preventable if people didn't smoke, avoided the sun, avoided alcohol, ate a healthy diet, maintained a healthy body weight, and stayed physically active. Okay, let's look again what recent research said about cancer. We know that cancer begins when a cell breaks free from the normal restraints on uncontrolled growth and spread. And this is happened due to many factors, including infection. And studies showed that the 4 most important infectious carcinogenic pathogens were Helicobacter pylori, high-risk human papilloma virus, and hepatitis B and C viruses, which together cause more than 90% of infection-related cancers worldwide. So this kind of infection is potentially modifiable risk factors for which prevention tools already exist. So that is a good news, people, because the risk factors of cancer, including infection, is really modifiable, and we actually already has the prevention tool, because the prevention tools is already exist. Okay, so can we prevent cancer? Yes, sure, we can prevent cancer. Now, how can we prevent cancer? Now, look at this, some of ways to cancer prevention. First is simple lifestyle changes. We need to change our lifestyle. We need to avoid tobacco. This is very important. This is the first thing to do if you are a smoker. You want to prevent from gaining cancer, you need to avoid tobacco, because tobacco is the leading cause or the first risk of many kinds of cancer. Second is avoiding excessive alcohol consumption. Third, you can do regular exercise, 30 minutes in minimum, and have a balanced diet. You need to eat healthy food and real food. Dr. Jun has already told you about the diet for patient cancer. And you can do prevention by maintaining healthy weight, because obesity and overweight are also the risk factors for cancer. And you also need to using sun protection to protect skin and eyes from the sun by avoiding direct sunlight between 10 a.m. and 4 p.m. because about 10 to 20% of the cancer case is including skin cancer. And the last one is do safer sex. Okay. Next, you need to develop appropriate screening schedule or regular checkups based on age, family history, and other risk factors. It is very important because you need to check your health condition, and it can be a early detection of cancer. And you need to do vaccination. We already know that Cancer also cause, or the risk factors of cancer also papilloma virus and helicobacter and hepatitis B and C virus. So to prevent this kind of cancer, you need to do HPV vaccine and hepatitis vaccine to protect you against the formations of hepatitis B virus and human papilloma virus related cancers. Okay, now we have do the prevention. We have done the prevention, but unfortunately, if somebody still gained cancer, or for if fail to prevent a cancer case, we can still increase the survival rate, the positive prognosis of the cancer by doing early detection. Cancer survival rates are generally increasing, and there have been improvements in survival for many types of cancer. And the cancer survival rates have increased due to a number of factors, including early detection. So early detection is very important. Improved screening has led to more early stage cancer diagnosis. And in this stage, treatment is more likely to be successful. So it can increase the survival rate. Okay, so how can we do early detections of cancer? Early detection of cancer can be done through regular cancer screenings and by being aware of your body. We start with the screenings. Regular screenings can help detect cancer before symptoms appear, even before the symptoms appear. And now we have a blood test that can detect eight different types of cancer. Before the symptoms appear, mostly the prognosis will be good, better, and the treatment will be easier. The American Cancer Society recommends screenings for breast, cervical, colorectal, prostate, and lung cancers. All right, and some screening tests could be include mammography for breast cancer, HPV and pap testing for cervical cancer, colonoscopy, sigmoidoscopy, and stool-based tests for colorectal cancer, and low-dose CT scanning for lung cancer. Now, early detection can be done by aware of your body. You need to aware of the signs of cancer, include a new lump or bump, or a lump that changes in size or appearance, and unexplained bleeding, bruising, or pain, unexplained weight loss or tiredness, night sweats, changes in bowel and bladder habits, changes on your skin, a new or changing cough, or blood and urine, your bowel movements, or from spitting. You need to be aware of this. You need to go to the health facilities to have your body checked to early detect if there is a cancer cell in your body. Okay, so after knowing all how to prevent and how to early detect cancer, we need to spread this information to the community. So we will going on to talk about education initiative for community. We will discuss what can we do to help the community. If you look at the community, cancer is a formidable health challenge. It continues to afflict communities worldwide. While the advancement in medical science have significantly improved treatment options, the early detection remains crucial in increasing survival rates. So what we need to do is raise the community awareness through education. Now, how can we do we do education for community? How to educate people to empower communities against cancer? There are some focus area, including understanding cancer. We need to educate people about a fundamental understanding of cancer, its types, its causes, its risk factors. It is very essential because this knowledge can help the individuals, can help people make informed lifestyle choices and recognize potential warning signs And we need to also address myth busting, addressing common misconceptions and myths surrounding cancer can dispel fear and encourage proactive health behaviors. Based on my experience, many people with cancer come to health facilities with end-stage cancer or late-stage cancer because they have some myth around surrounding cancer that become a hinder for them to early come to the health facilities to have their body checked to find if there is any other cancer cells in their body. So it will also hinders or delay the treatment for cancer patients. And we need to focus on the healthy lifestyle promotion. We need to encourage healthy lifestyle habits such as regular exercise, balanced diet, avoiding tobacco, again, and avoiding excessive alcohol consumption, because this can significantly reduce cancer risk. And we need to emphasize the importance of regular checkup. The significance of regular checkups, including screening for specific cancers, like I mentioned previously, such as breast cancer, colorectal cancer, cervical cancer, and lung cancer, because it can aid in early detection and timely intervention. Okay. And I aware that most of the participants in this international webinar is student and maybe health practitioners. So I need to emphasize that students and educational institutions actually hold unique positions to drive change in cancer awareness through some initiatives such as community outreach programs. Students can organizing community outreach programs such as health fairs, workshops, or webinar like this, and cancer awareness campaign. It can reach a wider audience and disseminate vital information about cancer, about how to prevent, and about the early detections of cancer. And volunteer initiatives, lecturers or can encourage students to volunteer in cancer awareness and support organization. It can foster a sense of social responsibility and contribute to community well-being. And then students also can include or join research and innovation. They can supporting research initiatives and fostering innovation in cancer prevention, detection, and treatment. It can lead to groundbreaking discoveries and advancements. And well, this is the important thing because this is a significant thing for Gen Z and millennials maybe to be a role modeling and peer influence. Students can be a role model. They can share positive health behaviors. Students are knowledgeable about cancer prevention and early detection. They can serve as a positive role models for their peers and for people around them by practicing healthy behaviors such as regular exercise, again, balanced diet, again, avoiding tobacco, and etc. And they can inspire others to do the same. They can use social media, the power of social media. They can be an influencer for positive health behaviors, and they can encouraging open dialogue, like creating a supportive environment where students can openly discuss health concerns, including cancer. They can reduce stigma and encourage help-seeking behaviors. That this can lead to earlier diagnosis and treatment. It can lead to prevention or lower the case of cancer, and it can lead to increased survival rates of cancer. All right, thank you. I think that's all that I can share with you all. I have 2 points that we must remember. First is cancers are prevented it enabling people to enjoy a more happy and healthy life. And when cancers are detected and treated at early stages, it can enabling more effective treatment and reducing morbidity and mortality. All right, thank you. I'm open for any discussion or any question. Thank you. We're going back to Sania. Thank you, Sania.
Okay, thank you so much for Mrs. Mira Utameningsi for the insightful presentations about how educating the society about cancer, how to detect cancer earlier by blood test as a screening test, and also increasing our own self-awareness about cancer and how to prevent cancer by changing our lifestyle to a healthy one. But besides, we also we know that she explained clearly to us about what exactly the burden of cancer itself. And before we go into Q&A sessions, let's move to our next speaker, Mrs. Niputu Sumartini, SCOP, Nurse NCOP. Miss, are you with us? Hello, Miss. Your voice is not in yet.
I'm sorry, I cannot hear you clearly. Sania?
Yes, you're audible now. Okay, well, this material will very special for nursing, but also for all of us, because Ms. Niputu Sumartini will discuss about improving the competency of nursing graduates in cancer treatment. For Ms. Putu Sumartini, please, the time is yours.
Good afternoon. Have you heard my voice? Okay, thank you, Sania. The Honorable Director of Poltekkes Mataram, the all committee of UPK Poltekkes Mataram, all speakers and participants who I'm proud of, even though have joined the presentation for 5 hours, but still join this webinar. First of all, I would like to say thank you for the opportunity for joining this international webinar. Please allow me to share my screen. Can you see my screen?
Yes, Miss.
Okay. In this final session, I would like to share and also learning about improving the competency of nursing graduates in cancer treatment. My name is Niputu Sumartini. I am a lecturer in Prodi Diploma 3 Keperawatan Nursing Diploma of Poltekkes Mataram, West Nusa Tenggara, Indonesia. Here are my email and also my phone number. I'm here because I love to share my presentation with all great participants and also speaker here, and also to learning more about cancer care, especially in cancer education and nursing education. Okay, before I start the presentation, I would like to remind a special day in cancer care, which is called named World Cancer Day on 4th February. And this year, the motto is Close the Care Gap, collaborative care treatment, and also fair and equitable treatment. Our topics for this afternoon is, there are three topics. The first one is the competency of nursing graduates. The second one is nursing curriculum. And the last one is subject of nursing diploma with excellence in care of cancer. Okay, I would like to explain the background. The latest WHO data shows that most countries do not provide adequate services for cancer within universal health coverage. Survey of 115 countries. And new cancer case in the world reached 20 million case with a death toll of 9.7 million case, according to International Agency for Research on Cancer. Other data in cancer care that only 39 of 150 countries included cancer management as a core health service for all citizens, which is this increasing the risk of death of the survivor and also cancer patient. The second data is only 28% of countries provide palliative services and still lack of oncology doctor in some countries. Other fact about living with cancer, according to the American Society of Clinical Oncology prediction, there is 81% increase in people who will be living with or surviving cancer by the year of 2030. Increase in the number of oncologists only 14%, which will result in a huge healthcare gap in meeting the needs of person requiring cancer care. And also the shortage of primary care physician, as well as the predicted shortage of nurses, will only compound the problem. Another fact about living with cancer, the survival longevity will greatly expand their needs for support. And demands of oncology nurses are the need of patients with newly diagnosed cancer, the needs of cancer survivors, and the needs palliative care for advanced disease. And the palliative care must be fully integrated into cancer care. Those nurses, as a part of health worker, give a bigger contribution in contributing to support a better cancer care. As we know that nursing competency is a nurse's ability to show the knowledge, skill, attitude, values, and personal characteristics that are required to fulfill their professional responsibilities. So, the developing competence is an essential component of nursing education to ensure nursing graduates are prepared with the essential knowledge, skills, and attitude to enter the workforce and functioning safely in entry-level position. So, what is the curriculum then? The term curriculum is derived from the Latin word currere, which means run. So this means as a blueprint of an educational program. The curriculum framework provides direction for the selection and organization of learning experience to achieve program objectives. Nursing curriculum is also the learning opportunities and the learning activities that the faculty plan and implement for a specified period of time to attain the objective. Nursing curriculum is the learning opportunities, subject matter, and the learning activities, clinical experiences, and practice that the faculty plans and implement in various settings for a particular group of students for a specified period of time in order to attain the objective. In other words, nursing curriculum is a planned set of learning experience that helps students develop the knowledge and confidence to practice nursing. There are three aspects in nursing curriculum. The first one is content. Nursing curriculum is based on a body of knowledge specific to nursing, including the art and science of the profession. The second one is learning experience. The curriculum includes a variety of teaching and learning methods, such as lectures, tutorials, workshops, and practical work. And the third one is learning outcome. The curriculum is designed to help students achieve specific learning outcomes, such as developing competency and professional attributes. Nursing curriculum is designed to help students develop the following skills and attributes, such as clinical judgment through clinical reasoning, critical thinking, ability to challenge assumptions through problem-solving method, broad knowledge base including anatomy, physiology, biochemical, and others, system approach, especially using nursing process approach, appreciation of diversity and professionalism, accountability for delivering evidence-based practice, also ability for lifelong learning, and collaboration with other health professionals. Step in curriculum construction, the first one is planning, continued with development of the curriculum, and implementation of the curriculum, and the last one is evaluation of the curriculum. According to Rob Taylor, there are 4 main steps or tasks in curriculum development. The first one is formation of educational objectives. The second is selection of learning experiences. And then effective and efficient organization of learning experiences, and the last one is evaluation of the curriculum. I would like to share the knowledge and experience from the curriculum development in nursing diploma study program of Poltekkes Mataram. So to meet the need of increases in care for cancer in 2023, we held a curriculum workshop. The result is a higher education curriculum with excellence in nursing, in cancer nursing. Here are some photos and documentation of the curriculum workshop. We invited 4 speakers from the Association of Vocational Education Institution and also from the Indonesian Oncology Nurses Association with the Director of Poltekkes Mataram. Now we move on about the curriculum preparation stage in Indonesia. According to Ministry of Research and Technology, there are 4 stages. The first one is determining graduate profile and learning outcome, or in bahasa we call it as capaian pembelajaran or CP. The second stage is selecting and assembling study materials. The third stage is arranging courses, curriculum structure, and determining semester credit units. And the last stage is develop a learning plan. For the graduate profile of nursing diploma in Indonesia, according to Association of Vocational Education Institution 2022, there are 4 graduate profiles. The first one is care provider, which as a nurse who able to provide nursing care to individual, families, and special groups in clinical and community setting to meet basic human needs. The second profile is an educator, as a nurse who is able to provide health education as health promotion and prevention effort to individuals, families, and special groups in clinical setting. The third profile is management and leader. This means that as a nurse team who capable of managing nursing care for individuals, families, and special groups using a nursing process approaches. And the last profile of nursing is researcher. As a nurse who is able to use research results as a basis of carrying out case studies on individuals, family, and special groups. And then after about the graduate profiles, we go on learning outcomes. There are 4 aspects of learning outcome and consists of 8 learning outcomes. The aspects are attitude and values, and mastery of knowledge and science. The next is general job skill, and the last is special skill. These are the learning outcomes. The first one is able to demonstrate an attitude of devotion to God Almighty and proud as an Indonesian nation that upholds human, ethical, legal, moral, and cultural values in providing nursing care, or named as KTL 01. Number 2 is able to understand nursing science to provide professional nursing care using the nursing process, especially in oncology nursing, KTL number 2. Number 3 is able to carry out therapeutic communication and master basic nursing skill to provide nursing care to clients through teamwork. Number 4 is able to provide health education in nursing care by developing communication skill and utilizing scientific information. Number 5 is able to provide nursing care to individuals, families, groups, and communities by prioritizing client safety and quality of service based on development in nursing science and technology, to improve the quality of nursing care by paying attention to caring principles in accordance with the professional code of ethics, especially in oncology nursing. Number 6, able to play an active role in nursing management and be responsible for their work in health services using the principles of nursing leadership and management. The last is able to improve skill in the field of nursing in carrying out lifelong learning. Here are the cancer continuum and nursing care, from the promotion or prevention when the cancer is not detected or found yet, and then early detection. The third continuum is diagnosis of cancer, continued followed by the treatment of cancer, and then become survivor, palliative, and then end of life care, and the last is mourning period. Caring is a process, not a single event. Jadi from this picture, we could conclude that caring is a process, not a single event. The second one is selecting and assembling study materials based on workshop result on May 2023. The first study materials is nursing care when diagnosed with cancer, and then nursing care when undergoing a cancer treatment, nursing care after cancer treatment, and palliative care. Then we go to subject establishment. There are 3 subjects. The first one is oncology nursing, given in second year with 2 semester credit units. The second subject is palliative nursing, given in second year with 2 semester credit units. And the last one is nursing clinical practice of oncology and palliative nursing, given in third year for 2 semester credit units. Oncology nursing, as we know, is a part of medical surgical nursing, which studies the care and also the treatment of cancer or tumor. Oncology nurses' duties is help patient understand physical, emotional, social, and spiritual needs, improve the quality of care, provide education to patient and their family. From the second speaker, we have known about the palliative care. Here are the brief definition of the palliative care, an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Here are the dimensions of quality of life from physical concern, symptoms, pain, until occupational functioning. We have understand that the cancer care needs interprofessional collaboration in, especially in palliative care, and the role of nurse is very important. Type of palliative care disease are cancer, chronic obstructive pulmonary, stroke, Parkinson, heart failure, terminal renal failure, HIV, and geriatric. Here are problems often faced by palliative patients: pain, psychological or mental problem, nutrition, sleep disorder, mobilization, cold or dyspnea, communication barriers, wound, or other bleeding, and lack support from family or environment. This problem, a nurse can give an intervention to relieve or to decrease the symptom. Here are the end of my presentation. The conclusion: increased number of cancer case and mortality due to cancer and insufficient cancer care need nurses with a competence in oncology nursing. There are 4 stages in curriculum preparation and subject due to a cancer: oncology nursing, palliative nursing, clinical practice of oncology, and palliative nursing. Here are the references. Thank you. We all have passion, something we love doing more than anything.
Okay, thank you so much for both our speakers for their excellent presentations. We're now entering the Q&A sessions, and we already have some questions for both our speaker here. We have questions from Alex Purba and also Fadila Rizky Ananda for Mrs. Mira. Mr. Alex is asking which level of society is the hardest to educate based on the case. And Ms. Fadila asking, since when some individuals can take HPV vaccinations, or is these vaccinations can cause cancer if we have a possibility from genetics, to make us realize and aware of the prevention of cancer itself? To Ms. Mira, could you please address these questions? Thank you.
All right, thank you, Sania. I will answer the first question from Fadila. The human papilloma virus vaccine, it can be given starting from age 9, but the CDC recommends getting it at age 11 or 12. And for adults with age around 27 to 45, they consider to get this vaccine directly soon. But if they didn't get it when they were younger, they should get it. But the benefit is less because more people in this age might have already been exposed to human papilloma virus. And the human papilloma virus vaccine is most effective when it is given before sexual activity begins. So, and it can prevent new HPV infections, but if you have already infected or exposed to human papilloma virus, it cannot treat the existing infections. Okay, and for the second question from Alex, well, I think all part of the community has their own challenges in educations about cancer, but in most cases, educations about quitting tobacco or smoke, either using electric smoke like vapes or any other types of smoking, is the hardest one, I think. And especially in our country, because smoking is like a habit, and in some traditional community, smoking is their culture. You may ever heard about an idiom that said, "You drink, I smoke." These idioms actually describe the culture in our country, or some of developing country whose habit is smoking, while in Europe or in Australia, people usually drink alcohol. So I think the hardest one is to educate people to prevent cancer by quitting tobacco or quitting smoking. That's the hardest one, I think, in any part of the community. Thank you, Sania.
Yes, I do agree with your answer. The tobacco one is the hardest. Well,
Yes.
now we still have our questions too for Mrs. Putu. There are two questions. How to cover up the lack of facilitations, human resources, or else for sustainability treatment for cancers. Also, which more impacting the curriculum or the interest from individual to study to cancer treatment. To Ms. Putu, could you please answer these questions?
Thank you for the question from Fadila and Laksmi. I would like to answer the question from Fadila first. In Indonesia, Health Ministry have designed some program to cover up the lack of facilitation, and also have planned to send the doctor to follow a fellowship program for 6 until 24 months abroad, especially to Korea, Japan, and also China, to learn about the oncologists. For the lack of facilitation, the Health Ministry already have a program to add the facilitation, especially the number of hospitals who able to give treatment for cancer patients, and also the facilitation for example is for radiotherapy, and then for chemotherapy, also for immunotherapy, and stem cell or immune therapy. For the question from Laksmi, which more impacting the curriculum or the interest from individual to study to cancer treatment? Will be nice if it come along together. The curriculum is complete and well set, and also the individual interest in study to a cancer treatment. But from my opinion, the curriculum will more impacting, because good design of curriculum will lead or will guide a student who is interested to study about cancer treatment to gain a better competency or good competency.
Well, thank you so much, Ms. Putu, for the nice answers. Yes, I do also believe that our government still there trying to do their best for against the cancer with us. So this is the end of our main sessions. What we can conclude from all the speaker is cancer is a disease that has high potential for death, but fortunately, it can still be prevented and treated in various ways, such as improving lifestyle, improving nutrition, and also undergoing a series of medical therapies. Thank you so much once again for all speakers and audiences. But before we end our sessions, let's having a pictures, let's having a text screenshot with our awesome two speakers. I think, can you please help us? Okay, 1, 2, 3. Okay, once again, 1, 2, 3. Okay, thank you so much once again. And now I'm giving back to MC Sania, and thank you so much.
Thank you to all speaker and Ms. Nusanya Fahmi Mantika for the lively discussions this far. So, ladies and gentlemen, as we approach the end of our webinar, we would like to express our heartfelt gratitude to all speakers, moderators, and participants for your invaluable contributions today. On behalf of the organizing committee, I apologize for any shortcomings during the event, and thank you so much, and we hope to see you at our next event. Good afternoon, guys.
Good
Good afternoon.
afternoon. Thank you. all.
Thank you.
See you, everyone.
Thank you.
Webinar itu.